अविनाश तू दिसत नाहीयेस, फक्त तुझं मागचं हे दिसतंय.
हो, मी अजून व्हिडिओ ऑन नाही केला.
ओके ओके, पण व्हिडिओ ऑन दिसतोय आम्हाला तुझा इथे.
नाही, ते टेम्पलेट असले तर काय ते
टेम्पलेट. ओके.
मॅडम, हॅलो.
हॅलो.
हा मॅडम.
गुड इव्हनिंग पराग सर.
Good evening all. Hello.
हा सर, we can hear you.
Good evening to all. Good evening to all.
Good evening. Good evening.
Chalo, thank you.
Good evening, ma'am. Good evening, sir. Dr. Sare and all.
Good evening. Good evening.
काय सर, गुड इव्हनिंग.
Good evening. Good evening.
सर तुमचं मागचं जे हे आहे ना बॅकग्राऊंड, इट इज सो नाईस.
Oh my God.
समुद्र किनाऱ्यावर बसल्यासारखं वाटायला तुम्ही.
अरे आता तू बघितलीस ना, कोणीतरी आलं होतं माझ्याजवळ.
आणि प्रत्येक वेळेस असं वाटतं की तुम्ही अक्षरशः, आणि त्या लाटांचा आवाज येतोय मध्ये, डिस्टर्बन्स झाला की मला वाटतं त्या लाटांचा आवाज येतोय. पनवेलकर मॅडमला फोन करावा लागेल का काय?
Dr. Hemangi, please unmute yourself. Good evening, ma'am.
Hello, good evening.
Yeah,
Oh,
good to
Good
see you.
evening, sir.
Good evening. How are you?
Very fine. Thank you, sir.
मनीषा खोंडविलकर मॅडमला एक सांगावं लागेल, तिथे कुठेतरी
जॉईन होतात मॅडम.
प्रॉब्लेम होता
She's
नेटवर्क.
trying to connect.
या शी जॉईनिंग. आय थिंक शी जॉईन. आता अजून मॅडम अनम्यूट नाही झाल्या. खोंडविलकर मॅडम, गुड इव्हिनिंग. मॅडम गुड इव्हिनिंग.
मॅडम.
काय झालं बा? गेलंच मध्ये. युट्यूब कनेक्ट झालं माझं काहीतरी, ते ऑफ करून टाकू. वर्षा मॅडम, तुम्ही युट्यूब लिंक घातली का मध्ये? कारण त्याला
हो येस मॅम.
वर गेले मी एकदम. ओके मॅडम, गुड इव्हिनिंग. मॅडम इथनं नमस्कार करते. मॅडम तुमच्यामुळे सगळं काही आहे. एव्हरीथिंग इज बिकॉज ऑफ यू.
खोंडविलकर मॅडम अनम्यूट करा थोडं.
म्हटलं सगळ्या स्टॉलवर आहे तिकडे.
मॅडम तुम्ही सुरुवात करून दिली म्हणून आज हा सेमिनार पण घडतोय.
स्टॉलवर हेमांगी इज देअर, देन yourself, साळे, डॉक्टर अनिल परब. I can't see him. Where did he go?
Is there? I
We
think
are
you
your
are
followers.
टाइम भी नहीं गया क्या?
Madam, we are your followers. Good evening, Dr.
Follow
Sri
you.
Ganesh.
Hi.
Good evening.
Hi, Shri Ganesh.
Good evening, everyone. Good evening, madam.
Yeah,
Good evening,
hi,
sir.
hi.
Good evening, dear.
How are you?
Madam, that's to me.
मॅडम आपण एक 5 मिनिटात we will start at 7:05.
Yes.
Yeah, no problem.
People are getting connected, so at 7:05 exactly we will start.
Fine.
Dr. Sri Ganesh sir, you are traveling somewhere?
Tomorrow
Yes,
I'm
madam.
going to Nasik.
You are traveling?
Yeah, I am traveling.
Okay. So thank you so much.
No problem.
You are joining in spite of hectic schedule and travel.
No, madam. That is the reason I sent my video ahead, so that if there is any problem with the technical aspects, so it should not be a inconvenience for all.
Yes.
साळे सर पुण्याच्या बेटावर गेला का तुम्ही?
हो.
हा, बेट बांधलं का? आम्हाला बोलवत हा?
पुण्याच्या भेटी.
पुढच्या वर्षी कॉन्फरन्सला बोलवणार आहेत आपल्याला सगळ्यांना.
हा.
पण बेटावर हा, पुण्याला नाही जात, खडकावरती नाही. आता म्हणाल की पाषाणला चला, इकडे चला, तिकडे चला असं.
नाही हो, नाही.
लुकिंग लाईक लाईव्ह इट इज, कारण पाणी पण हलतंय, झाडं पण हलतायत.
अच्छा अच्छा. आणि हेमांगी, हाव आर यू?
I'm very fine.
I'm missing you a lot since last 2 years. We haven't.
Yeah, we are rarely meeting.
कॉन्फरन्स आता सुरू हो दे, मग मी येते.
हो, भेटूया.
आला मॅडम कॉन्फरन्स रू.
नाही, हे असं भेटतं नाही. हेमांगी आणि मी, we always flock together in conference.
Now offline conferences have started. Aurangabad is going to be first offline. I mean CME.
अच्छा अच्छा.
चालू होणार.
This reminds me of a Trivandrum conference which we had in one this day. Hemangi, you are there, sir? Anil sir.
In the resort, no?
इस पे गए थे हम लोग ऐसे.
We had in the resort.
हाँ, resort में गए थे. Good.
Wasn't there? हाँ.
Good night to reach that resort.
Yeah.
तो बॉम्बे वापस कब कर रही है conference?
Not before 25.
Not before 25.
Yeah, because already 3 years are fixed. Next.
पता नहीं, 25 is too
Which are the
long.
places, sir? 3 years, which are the places?
हाँ?
Next is,
हाँ.
this year it was in Calcutta, but they could not do, no? So now
Yes.
probably next is again in Delhi. Yo, madam, Dr. Hemangi, am I right?
No, next is Hyderabad.
Hyderabad. Sorry, Hyderabad. Next in Hyderabad.
2022 in Hyderabad.
Yeah, 23. 22 already done. 23 is in
Yeah,
Hyderabad.
22 was done online. Yeah.
I
Yeah,
think,
Calcutta. It was in Calcutta.
yeah, I think Solapur is a better destination than Mumbai next time.
Yeah, we can
Definitely,
organize.
madam. Definitely, we will do it. कधी? Just tell me. आता तर मॅडमच आहेत. Dr. Devpujari madam is president of ISNAC, so we can do it in Solapur.
So next year we'll bid for the Sholapur.
Yes,
No
yes,
problem.
yes, yes.
We'll try.
वर्षा मॅडम तुम्ही सगळ्यांचे CV दाखवणार आहात.
Yes, 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 ma'am.
Yeah. Avinash, should we start?
Yes, there are already 42 people. You can start.
We can start. We'll start. Good evening, respected chairperson, respected Dr. Bharti Konvilkar madam, Dr. Anil Barak sir, today's faculty, Dr. Shri Ganesh Kamath, Dr. Hemangi Karnik madam, and all members of Maharashtra State Chapter ISA and outside MSCISA who have joined for this webinar. A very good evening to you all. When I joined my practice in Solapur in 1996 as a neuroanesthesiologist, the situation was totally different that time as compared to what it is today. Neurosurgery practices has been expanded in interiors of Maharashtra, in all the cities of Maharashtra, because of availabilities of neurosurgeon as well as the CT scan facilities. So today's topic, what madam is going to speak and what sir is going to speak, they will be applicable to all the neuroanesthesiologists who are practicing at the moment in Maharashtra. In 2001, I remember I had been to Hyderabad for one of the neuroanesthesia conference, and I had presented a paper that time, Propofol and Fentanyl, Magic in Neuroanesthesia. That paper had received Best Paper Award, but my dear friend Dr. Padmaja, she was in Nizam's Institute that time, and she asked me, Manisha, do you practice so much neuroanesthesia in Solapur? So this question asked almost 25 years back or 20 years back, the scenario has been totally changed now. There are many neurosurgeons who have settled in interiors of Maharashtra, and many anesthesiologists are practicing neuroanesthesia. So today's topic is very important for all of us who practice neuroanesthesia, and madam's topic, that is neurological patient for non-neurological surgery, is important for every individual anesthesiologist who is giving anesthesia to a patient who has either a stroke, a history of epilepsy, or a stroke, or a previous stroke. So let us listen from the stalwarts in neuroanesthesia about today's topic. Anita madam.
Yes, thank you, Manisha madam. And I am happy to introduce and welcome Dr. Shri Ganesh Kamath. Dr. Shri Ganesh has joined us. I believe he's traveling. Yes, Dr. Shri Ganesh is a professor at Department of Neuroanesthesia and Neurocritical Care at NIMHANS, and his interests are in neuroanesthesia, neurocritical care, pain, and research. And he has got many ISA awards: ISA President Award in 2021, Proficiency Award in 2019, research fellowships to Canada and ICMR International Fellowship, and many such awards. And he has got more than 140 journal publications and 8 chapters. Amazing, Dr. Shri Ganesh Kamath. Welcome, and I request Dr. Manisha to proceed further.
We have our second faculty today, Dr. Hemangi Karnik madam, Dr. Konvilkar madam, our chairperson is Dr. Konvilkar madam. May I request Sare sir to introduce Konvilkar madam? Sir, unmute yourself.
A very good evening to all. Fortunately, I have given the responsibility to introduce my teacher. And there is a lot to tell about the Konvilkar madam, because when I started my career, that time the most meticulous teacher in the theater, which I have seen, one of the Dr. Konvilkar. And there were two Bhartis, one of her friend, Dr. Bharti Avalegaon Kulkarni and Dr. Bharti Konvilkar. मॅडम बद्दल सांगावं तेवढं थोडंसं कमीच आहे, पण मी सांगितलं त्याप्रमाणे मोस्ट मेटिक्युलस थिएटर मध्ये. अँड इमॅजिन आउट ऑफ 39 years she has given her services in neuro anesthesia and critical care. With 30 years of experience in neuro anesthesia out of 39 years, unbelievable. Of course, everybody knows she is one of the alumni of the teacher and faculty of Grand Medical College, which is one of the prestigious institute from India. And after the retirement from Grand Medical College, she has joined the Neon Laboratory, which we all know well, as a medical consultant. Besides that, she has received many awards. Few I'll read it out. Top anesthesiologist in Mumbai City, Best Professor Award at GMC, Distinguished Teacher in Neuroanesthesia Award in one of the neuroanesthesia conferences. And she has delivered many lectures, but to distinguish some of the lectures in the past, oration lectures, particularly pain, past, present, and future in the Bombay University. Pitfalls in neuroanesthesia management in one of the national conferences of neuroanesthesia. Complications in neuroanesthesia, can we prevent them from ISA Pune? She has delivered in Pune. Now, publication, almost more than 20 publications and many platforms presentations she has done. Organized and conducted cadaveric workshop on pain management and regional anesthesia and difficult airway. Organized exhibitions for public awareness. What is anesthesia? Anesthesia, ICU, AIDS and blood transfusion, pain and its relief. These are the exhibitions she has arranged. She has played a pivotal role to get the sanction from the government of India and Prime Minister's fund. And that was almost 100 crores in upgradation of Grand Medical College JJ group of hospitals. And she has played a major role in treating various mass casualties during communal riots and serial bomb blasts and terrorist attacks. I am one of the witness when Salman Rushdie riot was happened way back somewhere in 89, probably 89, 90. And what a role we have played that time, and she was one of the lead role player during that right. She established OPD, MRI, anesthesia setup and services at such a group of hospitals, which was not there earlier. This is a recent one. She has also served as a technical expert for the procurement of the equipments, both the public sector and medical education sector in government of Maharashtra. She is one of the expert advice giving for the legal cases in the government of Maharashtra. And lastly, but not the least, she has played as a Corona Yoddha. She has set up 100-bedded Corona ICU in St. George Hospital during this pandemic, and she tried to get the mobilizing 25 lakhs donations to the government institute at St. George Hospital. So that is in short about the Bharti Konvilkar madam, but there is a lot to say because I have almost worked almost 8 years along with her, so I know her in detail. And whatever those days neuroanesthesia we used to practice, that esophageal stethoscope, prepare for the gloves or the precordial stethoscope and put into the ears. There used to be no monitor at that time. I have seen very, very closely to her. Thank you so much, madam.
त्याच्यावर आपण मत व्यक्त केलं पाहिजे. केंद्रीय तपास यंत्रणा राजकीय दबाव.
Hello.
Yes, Avinash, please continue. Varsha madam, mute everyone. Exclude, mute everyone. There are so many disturbances.
Varsha madam. Yes. Varsha madam, clear the screen. Yes.
Okay,
Thank you.
okay, sir.
Okay, thank you. I'm very glad to introduce today's another chairperson, Dr. Anil Parag sir. Sir is consultant neuroanesthesiologist and head of Department of Anesthesiology, Global Hospital, Mumbai. He was faculty and invited speaker for many national and international conferences. He was past president of Indian Society of Neuroanesthesia and Critical Care. Sir is founder secretary of Secretary of Association of Neuroanesthesiology and Critical Care, Mumbai. Sir is recipient of Literary Excellence Award in 2017 for contribution in the field of medicine, and it was awarded by Bharat Nirman Foundation. Sir featured 4 times in top anesthesiologist list of Mumbai, published by India Today. Welcome, sir.
Thank you. Thank you, Dr. Vinod.
Yes, Manisha madam.
Good evening, all. May I ask Varsha madam to start the lecture of
Yes,
So
yes, ma'am.
introduction of
topic is anesthesia for awake craniotomy. Varsha madam.
Am I audible?
Yes, अजून करा मॅडम आवाज मोठा. Screen करा. Full screen करा.
Complication management, and lastly conclude with the video demonstration of how awake craniotomy is conducted. So awake craniotomy basically performing neurosurgery, especially the craniotomy, the cranial neurosurgery in an awake state, and this is one of the image of awake craniotomy going on in our routine. So the indications are very specific for performing awake craniotomies. Mostly it is for epilepsy surgeries and for tumors involving the eloquent or the functional areas of the brain. Awake surgeries are also performed for stereotactic biopsies and functional neurosurgery such as deep brain stimulation, where it is a burr-hole craniotomy and not a large craniotomy. The special needs for functional surgery includes micro recording and clinical assessment, whereas for epilepsy surgeries, that could be electrocardiography monitoring and clinical testing. And for tumor surgery, it could be speech, motor, and other functional treatment. And anesthetic technique is largely awake for functional and stereotactic surgeries for most part. And for craniotomy and tumor surgery, it could be awake, or sleep awake. Very rarely, if there is an incidental extracranial problem, such as a large bulla in the left hemithorax, along with associated brain tumors, awake craniotomy may be performed to prevent the rupture of the bulla and also successfully decompress the brain. The contraindications for awake craniotomy can be divided into absolute contraindications, which include patient refusal, inability to stay still for a long period of time, and inability to cooperate for any reason. And relative contraindications are ones which are listed here: vascular lesion, learning difficulties, again inability to lie flat, anxiety, language barrier, obstructive pneumonia, morbid obesity, cough, and extremes of ages, especially young children. There are certain advantages of performing brain surgeries awake, and most important is the preservation of function and preventing neurological deficits with maximal surgical gains to avoid recurrence or residual tumor or need for any additional therapies such as radiotherapy or chemotherapy. Then other advantages include early discharge, improved survival, minimal adverse events associated with general anesthesia such as emergency delirium, ventilation problems, hemodynamic fluctuations. Better monitoring because patient himself serves as a monitor for awake procedures, high patient satisfaction, and probably lower cost. The limitation, most important one, is the need for patient cooperation. And then the surgical skills and speed, along with the knowledge of the anesthesiologist regarding conduct of awake craniotomy and managing emergency scenarios that might occur. And lastly, if the team or the hospital does not have expertise for special assessments such as EO potential monitoring or intraoperative MRI navigation, clinical psychological assessments, then that can be a disadvantage for performing awake craniotomies. Now, the preoperative preparation is the most important part of performing awake craniotomies. I have created a mnemonic called Educate. First and foremost is to establish whether there is a need for performing surgery awake and whether it is feasible in the current setup. Remember, this is an elective procedure, so this needs to be taken into account when you plan for awake craniotomies. Next is to develop rapport with the patient, because gaining patient's confidence and increasing his cooperativeness is critical for success of awake craniotomies. Third is to understand expectations of the patient from the healthcare givers and of the anesthesiologists and surgeons from the patient, because the cooperativeness is most essential, as I mentioned. And also what this patient should understand is that he will be lying in a fixed position for a long period of time. There could be sounds, lights, monitor beeps, etc. That he should be aware of. Consent for awake craniotomy will obviously be taken. You also need to take consent for likely conversion to a general anesthesia. Assessment is crucial. Assessment of airway, difficult airway is relative contraindication. There could be need for emergency placement of airway, so this should be planned and discussed with the patient. Elevate the anxiety, give prophylactic seizure drugs, anti-seizure drugs, assess cardiopulmonary reserve and neurological suitability for performing awake craniotomy. Explain about the testing that is likely to be undertaken during the intraoperative period, both clinical, electrophysiological, and imaging. Lastly, educate the patient in the preoperative visit about the entire process of conduct of awake craniotomy, maybe with a small video clip, or at least explain the steps involved, such as performing of the skull block, the sedation phase, awake phase, what are the likely assessments that are going to be performed. In the intraoperative period, you need to prepare the operating room for various stages of surgery. Mostly from anesthesia perspective, it has to be about the choice of anesthetic dose and drug, timing of its administration, and have a team ready who know their roles clearly, what they should be doing, when they should be doing, etc. Environment should be patient friendly for awake craniotomies, less noise, mild background music may be beneficial. Everyone should be prepared for their respective roles with regards to assessments. The anesthesiologist should come down on the anesthetic depth. The electrophysiologist should plan the appropriate testing. The clinical psychologist
वर्षा मॅडम काय प्रॉब्लेम झाला?
important. Patients often complain pain because of lying in particular position than at operative site. And lastly, preparation should be suitable for handling any complications that may arise, emergent airway, hemodynamic changes, blood loss, seizure, etc. These are some of the complications that we should prepare. So what are the goals of anesthesia? One is to prepare the patient for awake brain surgery. That is most crucial. Provide comfort during surgery. Titrate anesthetic analgesic drug as per the requirement of each stage of anesthesia and surgery. Facilitate cranial neurosurgery, and remember the basic principles of neuroanesthesia for neurosurgery. Facilitate neurological assessments during the awake phase, which includes clinical and electrophysiological assessment. Provide cardiorespiratory stability, and lastly, prevent and manage adverse events. So the basic two techniques: awake craniotomy, or asleep craniotomy. But a common element in both the techniques is good analgesia using skull block. Standard monitoring with respect to anesthesia should suffice, but we need to facilitate special monitoring for brain function. Lastly, standard interventions of neuroanesthesia, such as providing brain relaxation, antiepileptic drugs for seizure prophylaxis, steroids for reducing the brain edema, and nausea vomiting prophylaxis, pain relief, etc. has to be as usual for any neurosurgical procedure. In addition, we need to be prepared for adverse airway events, respiratory challenges, hemodynamic fluctuations, and these have to be taken into account during awake surgery. The critical aspect of awake craniotomies are good skull block. This should be successful and good to prevent any need for additional sedative or analgesic agent. Or its use should be minimized with good skull block. So there are 6 common nerves that are blocked. One, supraorbital, supratrochlear, which are the branches of the ophthalmic division of the trigeminal nerve. The zygomatic-temporal, which is the maxillary branch of the trigeminal nerve, and auriculotemporal, which is the mandibular branch of the trigeminal nerve. These cover almost the entire frontal or frontotemporal region, and so the awake craniotomy can be easily performed. Supratrochlear, supraorbital nerves come out of the supraorbital notch can be easily felt, performed. Zygomatic-temporal is somewhere just about the zygomatic process, midline between the tragus and the supraorbital nerve. And auriculotemporal is just anterior to the tragus, palpate the superficial temporal artery, just anterior to that, and used to the local. Each of these nerves can be blocked with 2 to 3 ml of local anesthesia. Posteriorly, you have to cover for occipital region, and here greater occipital nerve can be identified if the greater occipital artery is palpable, or about 2.5 centimeters from the ilion. Along the nuchal line, you will have to administer the drug. And posterior auricular nerve and the lesser occipital nerve are about 2.5 centimeters lateral to the greater occipital nerve. That will cover the entire spectrum of the scalp region on both the sides. Remember to administer on both the sides, because the patient will be on pins, though the surgery is on one side, and most of the time there can be a innervation from both the sides. The common drugs that are used are bupivacaine or ropivacaine. To enhance the volume, you can come down on the concentration around 20 to 30 ml or even up to 40 ml may be sufficient. But watch for the upper limit of the dose so that you don't exceed it and results in local anesthetic toxicity or seizure. The first technique which I'll discuss is awake, or conscious sedation or monitored anesthesia care, as it is called in different parts of the world. The primary emphasis on a good skull block for awake success. Minimal or no sedation, appropriate drug selection and dose selection is important. Earlier, we should do this craniotomy with a propofol fentanyl combination, but with the availability of dexmedetomidine, currently most awake craniotomies are performed with dexmedetomidine sedation and anesthesia using either manual infusion pump or a targeted. No artificial airway is placed in this particular technique. Good analgesia and comfort is essential. Avoid suffocation because patient is awake. Carbon dioxide buildup can occur. Patient can get irritated, start sweating. So you can play some video to keep the patient engaged, or at least some music which the patient can listen to avoid the noise and keep him engaged during the asleep phase. Challenges include seizure in an awake patient, extremes of carbon dioxide levels, and nausea. The awake asleep technique, a standard general anesthesia is administered with intravenous agent and maintained with either IV or inhalation agent. Mostly includes sevoflurane or desflurane, and IV includes propofol and fentanyl. Invariably, an artificial airway is placed. It could be a supraglottic airway device or endotracheal tube, and this will be required for the asleep phase, that is the beginning and end phase of surgery, where controlled ventilation is required. The mid phase or the assessment phase, there is no general anesthesia administered. It could be low dose of inhalation or IV anesthetics, and spontaneous respiration is maintained. It's important that depth of anesthesia monitoring be performed in asleep because you have to transition between different phases of sedation, and this will help you in titrating the anesthetic depth and ensuring a smooth transition. Again, the goals of neuroanesthesia to maintain cerebral and systemic dynamic as close to normal as possible is vital. The challenges in this particular technique are loss of airway, respiratory depression, desaturation, and lack of cooperation, especially during the transient phase when patient is becoming awake from sleep or for assessment. So this is a systematic review which compared monitored anesthesia care or awake technique with asleep, awake, asleep technique. And the conversion rate or the conversion rate of general anesthesia was higher in the asleep technique, or the discontinuation of the awake craniotomy was higher in the sleep technique. Post-operative nausea vomiting, not much difference. Intraoperative seizures occurred less with the sleep technique because obviously propofol. The duration of surgery was shorter with awake craniotomies, and hospital length was almost similar between the two. So the advantage in terms of shorter duration of surgery and higher success rate of awake craniotomy with awake technique. So there are certain challenges that might be seen during the awake craniotomies, and these include agitation, especially for the long duration, so inadequate anesthesia, inappropriate choice of sedative agents, and inadequate anesthesia. And this can easily be addressed by providing patient comfort, encouragement, proper patient selection. Inadequate sedation has to be addressed by providing good sedation, better choice of drug and dose, and good analgesia when the skull block is insufficient to provide analgesia. Airway compromise, desaturation, hyperapnea is invariably because of the excessive sedation. So we need to stop or reduce the dose. May need to ventilate the patient with bag mask, jaw thrust, airway instrumentation may be required in terms of the airway or even laryngeal mask airway or any technique. Hypertension is mostly because of the discomfort or stimulation, antihypertensive medication, and going up on the sedative dose may be warranted. Seizures are quite a challenge. It could be because of the cortical irritation or because of the pre-existing seizure disorder that the patient has, and the anti-drug levels will come down because of the blood loss. Anti-drug dose, double the dose of the case will be warranted. Excessive sedation or ill-timed sedation can lead to somnolence, and therefore need to be titrated actively. Hypothermia is common, especially in elderly patients who are exposed to room temperature. Active warming is essential in this patient. Now, coming to the assessment, apart from clinical assessment, electrophysiological assessment is invariably performed during awake craniotomies. It could be one or many of these which are listed here. EEG is used to titrate this anesthetic sedation and to monitor for seizures. In patients with seizure disorder, electrocardiography may be required to identify the seizure foci and to assess the complete resection of the tumor. For functional surgeries such as deep brain stimulation, microelectrode recording may be used, and sedation dose and drug should be carefully selected in these patients. Most commonly used wave potential monitoring are motor wave potential and sensory wave potential in awake craniotomies. Apart from this, there may be need for direct cortical stimulation to assess the hand, leg, face, and speech areas, and subcortical stimulation to assess how close or how far you are from the motor tracts so as to avoid post-operative deficit. And lastly, phase reversal may be needed to identify the central sulcus, which can be distorted with large tumors because of the brain edema, and therefore accurate identification is essential to separate the motor cortex from the sensory cortex. So I'll just play a quick video of identification of the cortical areas using the earlier techniques where you use the augmented stimulator. Here, the face area is identified and the hand area is identified by direct cortical stimulation and identifying hand areas of the brain so as to avoid any deficits in the post-operative period and yet resect as much brain area, tumor area as much as possible. And this way you can label the hand area and so that you can avoid particular areas such as face and to prevent any post-operative deficits. So imaging assessment is generally done preoperatively to merge the various imaging modalities such as diffuser tensor imaging, which provides a good idea about the tracts, and functional imaging to see if there is transfer of the functions from one hemisphere to the other, especially the speech. These are often merged with the intraoperative navigation system so that we get a live feed as we operate regarding the structural anatomy. And this can also be combined with the intraoperative ultrasound and MRI to assess the completeness of the section or to even identify the accurate site of the lesion if it is distorted. Neuropsychological evaluation of different domains is difficult in as complete evaluation package, but shorter versions are available to quickly assess these during awake craniotomies to preserve their cognitive functions. Most important role of anesthesiologist is prevention, identification, and management of adverse events which are likely during this procedure. Mostly awake procedures are associated with airway and respiratory compromise, which could be in the form of hypoventilation, airway obstruction, apnea, hypoxia, hypotapnea. Need for artificial airway may be present in an emergent scenario. So, and should be convergent with placing of LMA or conversion tube if required in this situation. Cardiovascular adverse events are common with anesthetic drugs that we use. Arrhythmias and bradycardia are likely with dexmedetomidine. Hypotension is likely with propofol. And hypertension tachycardia is likely when a lower dose of sedatives are used or when there is patient is uncomfortable or agitated. The anesthesia technique related are, as I mentioned, inadequate or excessive sedation leading to other problems which are mentioned above. Local anesthetic toxicity, if you don't take into account the total volume and dose of the drug used for scalp block, and surgeon also uses for infiltration. Pain, discomfort, nausea, vomiting can be present, and this needs to be handled. Surgery-related complications can be unexpected. Seizures, you have to be prepared for it. Venous thromboembolism, again, difficult to manage in a awake patient. Focal neurological deficits are likely, but less as compared to anesthetized craniotomies. Brain swelling is more likely because the patient is breathing spontaneously. We cannot manipulate the carbon dioxide level. So, pharmacological such as mannitol or ipratropium may be required. Psychological related includes anxiety, agitation, tiredness, fatigue, especially in later part of the surgery, and revoking consent and requesting for a general anesthesia may be present. So this was the study published from AIMS where they looked at different complications and their incidence and compared them with the earlier technique of fentanyl propofol versus the current technique of dexmedetomidine. They did not find a significant difference between the two, except for the lower incidence of seizure in the propofol technique as compared to dexmedetomidine. Now, airway compromise or need for airway may be present in awake craniotomies. This is a part of sleep-awake asleep technique, and there can be challenge in removal of the airway and reinsertion during the second phase and the third phase. Airway intervention may be required to protect airway from secretions, to rescue the compromised airway because of oversedation or apnea, to reduce brain swelling from hypoventilation and desaturation, and lastly to manage seizure, uncooperative patient or a procedure complication. There can be obstacles for emergent airway management during awake craniotomies, and we should be cognizant of this fact and prepare ourselves. The presence of basement head clamp restricts the head and neck movement. Need for maintaining sterile operative field, non-availability of space at the head end of the table, acute changes in neurological cardiorespiratory states, giving very limited time for securing the airway. These are some of the challenges that one may face when airway management is required during awake craniotomy. The most common rescue device used is supraglottic airway and video laryngoscope can be used to facilitate definitive airway placement in this scenario. So this was a patient with developed intraoperative seizure and had ictal apnea during the resection of the epileptic foci. And once you be cognizant of that, you stop the stimulus, the seizure stops, then the spontaneous respiration resumes. This is another example of how a pre-existing pontine lesion can result in baseline respiratory abnormality. This particular patient had a change of respiration, and here the choice of the sedative drug and the dose becomes very vital. We used dexmedetomidine instead of propofol and maintain spontaneous airway in this particular patient for a stereotactic biopsy. The most common fear is the problem is desaturation, and the common techniques of providing oxygenation in awake craniotomies are through the nasal prongs, which provides very minimal oxygen levels, and then oxygen by mask is slightly higher level, and use of nasal high flow oxygen devices can increase the oxygen flows that are delivered to the patient and also the increased FiO2. Thereby, it allows us to go up on the sedative drug dosage, provides a safety margin of desaturation, And it can also be used to prevent some degree of airway obstruction or carbon dioxide management. These are the statistics of awake rhinotomies in our institute. In the last 10 years, on an average, we have performed about 14 per year, that is slightly more than one per month. And I will play the video which demonstrates the conduct of awake rhinotomies in one of our patients. And after that, I'll conclude with the summary. So this is frontal glioma abutting the motor cortex. MRI tractogram shows the displacement of the internal capsule and the motor tracts. We need to maintain silence and minimal noise during awake rhinotomies. We use a fentanyl bolus and dexamethasone infusion to sedate the patient before we went ahead with the skull block. And here you can see the supratrochlear and supraorbital nerve block with the bupivacaine. And the volume that is used is about 1.5 to 2 ml. If each subsides, this is zygomaticotemporal nerve block, and then we move on to the auriculotemporal nerve block by palpating for the superficial temporal artery. Posteriorly, we first block the greater occipital nerve, just medial to the greater occipital artery, along the superior line from the about 2.5 cm from the ilion, if artery is not possible. And then we perform a ring block to accommodate both the posterior auricular and lesser occipital nerve, again along the superior line, and we inject about 3 to 4. Some of the patients might require intra-op MRI, so you should use an MR compatible frame so that the metal does not go into the MRI. And surgeon performs the registration of the neuronavigation. At that time, you can apply the scalp and peripheral electrodes to perform physiological monitoring. You can use the EEG from the same system and to assess the depth of anesthesia. And this is how the OT arrangement is done. We should have good access to the patient. The patient should not be suffocated because of the drapes that is to keep the operative area sterile. We use infusion pumps to deliver a constant sedation depth. And then it should be possible for us to assess the patient and communicate with the patient. Next, central sulcus localization is important because this anatomy can be distorted, as I mentioned. So use image guidance to identify where it is located. And in addition to image guidance, also place a strip electrode of 4 electrodes to identify the motor and the sensory cortex. The place where there is a reversal of polarity, you can see in the third row, there is a reversal of polarity, and that is the central sulcus. Once that is identified, it becomes very easy for the surgeon to go into the precentral gyrus in the motor cortex and assess the hand area stimulation. So here you are seeing the clinical response to the stimulation of the motor cortex. You can also see that on the EMG, which you have put for monitoring, and then you proceed for tumor section. Remember that the patient can have seizures at this point in time. It could be non-convulsive seizure where clinical manifestation may be absent, but on the EEG you can identify non-convulsive seizure, and you need to go up on the anticonvulsant dose at this point in time to prevent convulsive seizures. Hemodynamic stability has to be maintained with dexmedetomidine, and then surgeon again performs his assessments to see the depth of his resection and how far he is from or how safe he is from the motor tracts, so as to avoid any post-operative deficits. We can combine that with ultrasound guidance and with subcortical tract stimulation. This subcortical stimulation has advantages that you know the distance from the cortical tracts to the lesion area. It's about 12 milliampere current, it's about 1.2 centimeter away. You know that you are safe. You can go up further on the resection and not cause any post-operative deficits. But if there is no response, and then you need to stop at this level. Next, if it's involving the lesion is involving the speech area, you need to do speech area mapping, and that can be done by assessing for the speech clinically. You are asking the patient to count continuously. Suddenly, after 8 speech arrest occurs, you ask them to repeat it. So after 1 to 11, you stop. And then you go for resection further to identify so that achieve a maximal resection. That is the goal, and to avoid any deficit. So you combine multiple imaging modalities here. Ultrasound is also used to see any respiratory tumor is there, or cavity is good, and the distance on the ventricle. In some scenarios, you may have to perform an intraoperative MRI and all MR compatible instruments alone can go into this room. So your tube cannot be flexometallic. You cannot have bar screws in place. So your separate frame and tables are needed. You can't use the Mayfield clamp that's commonly used. And that way, the surgery is completed. And so this is just a brief video of how it was done in one of our patients. To summarize about awake craniotomy, as I mentioned, the goal is to maximize surgical goals, whatever it could be, tumor resection or seizure cessation, with minimal functional impairment, minimal deficits. That is the primary objective, and that should be the focus of awake craniotomy and purpose of it. Anesthesiologists should have sufficient knowledge about the entire process of awake craniotomy, the imaging, the requirement, and necessary skills to attend to an emergency such as emergency airway management, seizure prevention and management. So these skills are required to successfully conduct an awake craniotomy. Remember, there is a team effort. The radiologist, the anesthesiologist, the surgeon, the psychologist, the electrophysiologist, all are part of assessments and to have a good outcome for the patient. The combination of assessments are advantageous because it gives an increased margin of safety, but limitation could be it may take longer time and patient can become restless. Lastly, remember that awake craniotomy results in very good outcomes for the patient, higher surgical resection, minimal deficits, good satisfaction, and lesser hospital stay. So with these things in mind, with this knowledge, I think we all can provide better care for our patients who need it. And this is about awake craniotomy. And I'm open to take any questions on this particular. Thank you for your patient listening.
It was an excellent lecture by Dr. Sri Ganesh Kamar. And there are many queries, but we will discuss the queries at the end. Before that, I would, for both the lectures, we will take the queries together. I would like to ask Dr. Kondvilkar Madam, in fact, I would like to have expert comments from our chairperson, Dr. Kondvilkar Madam and Dr. Anil Parakh sir. Madam, please unmute yourself, Madam.
Congratulations, Dr. Ganesh. I think your presentation was just very, very simplified manner. Although the contents were this thing 100%, and I've never seen this thing lecture so this thing lucidly. You have almost covered everything that is required to know about the awake craniotomy. In my 30 years of experience, my anesthesia started with the boil field, and as Dr. Sare very correctly mentioned that we used to have this thing, esophageal stethoscope to monitor the heart and the respiration. At the end of my distinct, the neurosurgery OT was well equipped with everything, anesthesia wise as well as the neurosurgical equipment. And then in the last 5 years' time, we have done few awake craniotomies. So I won't boast that I must have hardly done about 20 cases of awake craniotomy in the eloquent areas. But many stereotactic surgeries. And for us, the stereotactic surgery, it used to be an ordeal because our MRI and the CT scan setup is on the ground floor and the OT is on the 5th floor. So you can imagine that we had to anesthetize, then we have to anesthetize the patient in the service because the CT scan was not very well equipped for the anesthesia. So we probably would anesthetize the patient, take her in this thing on the trolley with the ventilation and go down and then calculate the ordinates and come. To my very little experience in this particular area of neurosurgery, I would say that the patient cooperation is absolutely mandatory. And the type of patient that we receive in the public hospital, they are usually from the rural areas, wherein the language problem is also there. Sometimes we don't understand, although they might be speaking Marathi in Maharashtra, but their dialects are different. So understanding, explaining them the entire procedure, sometimes getting them in the empty OT and telling them that you would be like this, you would be sleeping like this, we would do this, we would do that. Like it is like enacting the drama before actually doing the procedure. So making the patient realize that he is going to undergo this procedure tomorrow and this is how he is going to cooperate. That was a big ordeal. That is one thing. That was a big hurdle, and I am sure that you all must be also spending a lot of time for this, for convincing the patient to lie down quietly for say 4 to 6 hours if the surgeons are pretty fast, or maybe more than that. Secondly, no one who's on a learning curve should participate in this, neither the anesthetist nor this thing. You must have a person who's very quick in finding out this thing, what are the airway difficulties which are coming in and how to secure them. So you must know that in all situations, in all positions, how to secure the airway and what are your limitations. What do you have in your cart to secure the airway if the airway is lost? Okay. Of course, you'll find probably it is little tricky, but then when we had no LMAs in the thing in our OT, that time very standard on my table, I used to have 5 or 6 number nasal red rubber tube. That I used to always put it in the thing boiling water, make it soft. I used to always examine the patient nose for the patency. And I used to very well explain him that you will have this to be a nose, find out the patency of this thing, and I used to keep that as a nasal airway. So obviously, whenever we used to find any problem, we can just go inside and there is a patent airway, we can connect at least the vein circuit or any other oxygen source and the patient get this thing. This would prevent the falling tongue also obstructing the airway completely. So much so at a later date, I myself trained myself, to putting the element in any odd position, standing by the side of the patient, standing on this side, that side, because it is very difficult to go at the head end and secure this thing airway in this case. So I used to always find that nasal airway or nasal that tube that on the trolley very, very handy to secure the airway in such cases. Other I used to always put in such cases and put my oxygen source to that and put in a vein circuit so that I could watch this thing respiration very well. Regarding again, how to our regimen of your sedation that you use, whatever you choose, whatever you are expert in, whether fentanyl, dexamethasone or whatever it is, we don't know how the individual patient is going to react to that. Although we generalize the saying, okay, this is a dose that we should, but remaining within the framework of that therapeutic range, sometimes the patient may just go out of the thing and then it may create the distinct situation. So airway emergencies are extremely careful, and therefore your team must have who can identify these cases, and they must immediately be ready that okay, this is now happening, I must do or I must assist my senior like that. Okay, it's a teamwork, and the team has to be very, very competent enough to take care of these problems if they come in front of it. The third thing that I would like to that, okay, now to go and get the success of this awake craniotomy in these days, we require a lot of monitoring. The standard monitoring as well as your have a specialized monitoring. As you say that we may have to map your brain and so many things are there. So therefore, I think we should not venture undertaking this procedure unless and until we meet this requirement. We should not just take it, okay, let's go and see how it happens. No, we should not. We should see our setups are really meeting the requirement of that particular procedure. Because ultimately we are going towards a more safer and safer surgical procedure or anesthetic procedure to minimize least damage to the brain tissue and for the better outcome. So my advice, or rather, I wouldn't say advice, my suggestion that people who are in the audience should see that whatever requirement of for the doing a awake craniotomy, whether it is awake, or it is a sleep awake, whatever way you want to do it, see that you are equipped with the all possible airway devices, all possible monitoring devices, and you have the distinct expert assistants along with you so that you can get over all the distinct problems. So many times we had difficulty. The surgeon used to be always insistent, no, we will do put a frame, stereotactic frame under local. They used to be hesitant. This is my experience. They used to be hesitant for us to give the scan block. Oh, we don't need this. We will just put in the local and we put the frames. But then somehow or the other, I could convince them that the scan block will be better, it will be nicer, and the patient will be quieter. And after a lot of effort, they got convinced that the scan block is really good. Then and it becomes easier because the patient who lies in the CT scan for longer time, till the time you calculate the ordinates, vectors, and everything, and then he's been transported from the CT scan to the operation theater long time, and then probably only the distinct burr hole, and there used to be a lot of endoscopic surgery. So maybe assist or maybe something like that is going. So the surgery might take little lesser time, but then putting that frame takes a lot of time and a very painful procedure. So these are my distinct suggestions to young audiences. Hello? Am I audible? Hello?
Yes, madam, you are audible.
Yes, madam, you are audible.
These are my
Continue.
suggestions to the young budding neuroanesthesiologist. And Dr. Ganesh, you have been excellent. And let me congratulate you. You have so many publications and so many awards to your credit. We haven't met every time in person, but next time definitely I would like to meet you and discuss certain things with you. I knew your seniors from Nimans, right from Dr. Rao and Dr. Venkat and all that. So congratulations once again for a very nice presentation. Keep it up. Thank you.
Thank you, madam. Madam, we will discuss all the queries at the end. I request Dr. Sri Ganesh to remain with us till the end.
Sure.
Yeah. I request Anil Parak sir for his expert comments.
Yeah. Thank you, Dr. Sri Ganesh, for the nice presentation and the nice video, which were well compiled. So we could see exactly what is happening during the surgery. The important thing is what I feel about awake craniotomy is the selection of patients. Even if you have a younger patient, like I had done it like 12 years a boy, I could make out that he is going to cooperate. And when we convince him with the parents and the counseling 2-3 sessions, we could convince. And there are patients who are adult, which we could not convince them. So the selection of patient is very important, and the surgeon and you should be on the same page. That's a very important thing. In my experience, as you described about the two techniques, like one is awake, other is sleep, awake, awake, sleep, awake, sleep. Okay. So in my experience, what initially there was no propofol, so we never used to give thiopenton or Tiva like situation initially. So now the situation is different. Many people use propofol infusion till the craniotomy occurs, and the propofol recovery is not very rowdy. The patients are not rowdy. So what happens that this technique is now a little more popular as compared to the full awake recognition because of the new drugs which have been there, like even dexmedetomidine. When they are clear-headed, when you stop the drugs, they are clear-headed. It's not like the previous thing. So many people have started using the sleep, awake, and sleep. And we never intubate these patients. Like we put an LMA and then many times we remove it and then make awake. So that is relatively when they are coughing and all this brain can come out. So that's the important thing is the patient should be very calm, quiet. And second important thing is you should be with patient all the time. It is not that the constant communication is the key for the success for the awake craniotomy. That's my main thing, which I'll say. Always communicate with the patient, always with the patient, even when you are sedating him, Tiva for initial period. As soon as you stop it, start talking to the patient, and when he's in full awake, clear-headed, that is the time you must test it. Because whatever the hard work you are doing, if suppose the patient not awake when you want him, then the whole procedure is not fulfill your demand. So I think that is the key, the selection of patients, and always with the patient. Even like smaller things are very important, like catheterization. Many times the surgery lasts for 4 to 6 hours. So if you feel your surgeon is smart enough and you can do in like 3 hours, then no need to catheterize such patient, because many times when they are awake constantly, the catheter bulb always irritate them, and they always say, I want to pass urine, I want to pass. That is the first thing that happens. So you must convince the patient, yes, there will be catheter, there will be some sensation, but you can pass this urine. And other important thing, your climate, the OT temperature. It is so important. These are small things, but when you are doing, like even a corporate hospital, the OP temperature is 17, 18 degrees. So you make the patient comfortable. That's a very important aspect. And many times, like 2-3 times, I had convulsions during excision of the tumor. So your surgeon should know, you like cold saline irrigations and all. It should be available. It should not like when convulsion, you are just finding where is the cold saline. So these are the small things, but very practical tips. And once you are your surgeon, you and the whole staff, like as you rightly pointed out, it should be calm and quiet. Many times we talk irrelevant talks. So when the patient goes post-operative, he say, this doctor was talking. There should not be any loose talks. You should always be focusing on your patient. These are small things, but they always remember throughout their lifetime. Yes, doctor was talking rubbish, and they were chit-chatting, they were abusing each other, they were abusing the ward boy. Even if you tried, the suction is not working, do something, bleeding. That small thing stuck to the patient, and they throughout their life, they say, there was a bleeding. So these are the small things, but when you are doing these things, you must remember that you should consider the patient is the prime important. It's not like patient is general anesthesia, and our requirement, OT temperature, even small things are very important, and you must think all the things. You must write down what has to be, points has to be there, and you should not be loose talk. You have to train your surgeon also. Don't shout unnecessary. Tell ward boys, nurses, whatever, like jail form, the surgical, everything we should be there. We just tell it should be available. You should not open the door, even the corridor, because many times people talk loosely in the corridors or out little far, and they listen and they remember completely for throughout their lifetime. And they always say wrong thing about the medical profession. So be careful. Awake craniotomy, it looks very easy. It's easy, but when it with the expert hands and the expert surgeon and the expert staff and everything, it's a team effort. Thank you very much.
Thank you so much,
Thank
sir.
you, sir.
Thank you so much. In fact, you
Most of these
created the.
points are also applicable to the surgery we are doing in regional anesthesia also.
Yeah,
Yeah.
very true.
Absolutely.
Very true.
Yeah.
Yes. Thank you so much, sir. We will discuss all the questions at the end. Before that, let us continue with one more remaining program. In fact, I should not say remaining program, but the continuation of International Women's Day celebration 2022. We had felicitated important prominent office bearers of various societies, lady anesthesiologists, and that time we had invited Dr. Vrishali Ponde, but she was busy in emergency cases that time, so she could not join. So I would like to invite Dr. Vrishali Ponde for the felicitation. Vrishali madam. I don't think Vrishali, my good friend from JJ Hospital, both belong to JJ Hospital, Ponvilkar madam student. Does she need any introduction? I don't think so. Madam, Varsha madam, slide moti kara. Yes. She is President, Managing Trustee, and Founder Secretary of Academy of Regional Anesthesia India. She is Director of Children's Anesthesia Services in Mumbai, attached to various hospitals. She is Program Head of WFSC Children's Anesthesia Services. Pediatric.
Varsha madam, are you there? Please.
Yes, sir.
Yes, I'm so sorry for the interruption. She is WFSA Pediatric Anesthesia in charge of Educational Committee from 2021 to 2024. AORA and CAS Pediatric Regional Anesthesia on the Educational Committee, 6 months fellowship course. ASPA E-Education Chair and Executive Secretary of Asian Society of Pediatric Anesthesiologists from 2022 to 2024. She works as regional anesthesiologist and pediatric anesthesiologist in various institutes of Mumbai. and she has represented Indian perspectives on regional anesthesia in various countries. She has already got international and national research publication, has been selected as top docs in India consecutively for last 4 years, recipient of Bharat Jyoti Award 2020, nominated for Rashtriya Gaurav Puraskar 2022, and we all know her hobby of sitar playing. We have seen her playing sitars on various social medias, and she has participated in the Halinga Academy of Sitar, in Shiva Sangitanjali and Guru Purnima programs. So welcome, Vrishali. We would like to welcome you. And we are really proud of you, proud of all your achievements. And as a friend, in fact, I was junior to you in JJ Hospital by 6 months. So you had taught me basics of anesthesia in the beginning of my career in JJ Hospital. I'm so proud of you, Vrishali. Welcome.
Wow.
Yes, Vrishali, we would like to talk for your achievements.
Please accept our felicitation. Ma'am.
Yes. Thank you so much. And these thanks are heartfelt. Actually, I never prepared anything to say because I thought that it must come extempore. Yes, Manisha is a very, very dear friend. And I think the generations of JJ Hospital anesthesiologists are here. It starts with Kondwilkar madam. And probably even the younger ones are here, younger than me and Manisha. And of course, I remain the youngest. All right. Well, so thank you very much for all that you have said. Thank you very much for the remembrance. Thank you very much for the detailed CV reading that you have done. And I'm hardly a neuroanesthesiologist, but the awake craniotomy and the regional blocks for that intrigued me. I have seen one awake craniotomy in an adult done by Dr. Parikh when we both worked in Seven Hills together. I'm not too sure if Parikh sir remembers that, but I do.
Yeah, I don't know.
Yes, so heartfelt thanks. No words, but thank you very much. And it's very encouraging. I shall do my best to make JJ Hospital Anesthesia proud and all of you proud. And perhaps continue whatever little work I can do. Thank you so much.
Thank you so much. Yes, Avinash.
Thank you, madam. We'll proceed to our second lecture. I am happy to introduce our second guest speaker, Dr. Varsha, madam. Please. Dr. Hemangi Karnik, madam, she is a professor in anesthesiology and in charge of neuroanesthesia. At present, she is in Lokmanya Tilak Medical College and HOD. He done a fellowship in Hargobind Foundation Medical Fellowship. Then hello.
Avinash, you are audible.
No, he's muted now.
Avinash, unmute yourself. Unmute.
Yes, she is a visiting professor at Stanford University. She is a reviewer for 5 journals and editor. She is editor of Practical Approaches to Anesthesia for Emergency Surgery, JP Brothers 2011. Then she is editorial committee member of Journal of Neuroanesthesia and Critical Care. She authored 9 chapters in various books. She had publication in her name 49, and she is assessor. Madam is assessor for MCI and National Board of Examination and MUHS. She is interested in neuroanesthesia, neurotrauma, and monitoring. I request Madam to deliver her speech, neurosurgical patient for non-neurological surgery. Welcome, ma'am. Please.
Thank you for the introduction. I can share my screen only after the current sharing stops. Yeah, thank you. I hope my slides are visible.
Yes.
Yes,
Yes,
madam.
madam. Yes, yes. Please continue, madam.
Thank you for the introduction. And at the outset, I would like to thank Maharashtra State ISA for giving me this honor and opportunity. I believe we all have come across neurological patient coming for some sort of non-neurological surgery, and it's practically experienced by all of us. When we say neurological patient, that means the brain has been made vulnerable by either trauma, ischemia, inflammation, neurodegeneration, hypoxia, seizures, and so on. And in addition, when they come for surgery, probably the effect of anesthesia drugs will further alter the function. Hypoxia and hypotension can also be present because of anesthesia drug. Surgery itself can cause fluid shifts, blood loss, tissue injury. All these things can add insult to the delicate brain. There are many types of neurological diseases present which we come across. However, it will not be possible for me to cover all. I will be taking few common ones only. Starting with the traumatic brain injury, as we all know, traumatic brain injury contributes to the 30% of all injury-related deaths. Sorry. And it's a major cause of disability in young, productive people. Unfortunately, when there is polytrauma, 70% of these patients are likely to have traumatic brain injury, and they may require extracranial surgery with varying degree of urgency. Sorry. The surgery may be emergent in nature for acute life-threatening bleeding control. It may be urgent if, for example, say for fracture fixations, later on the patient may come as elective surgery, either trauma-related or for incidental surgeries. But whatever is the nature of the surgery, the anesthetic management always offers some challenges to us, especially in the emergent situation. Which surgery gets priority? Which intervention should be done first? How to reduce the ongoing injury and preventing secondary injury are some of the common challenges. Secondary brain injury, as we all know, can occur because of the multiple factors. Increased ICP, hypotension, hypoxia, all these things can add to the injury, mainly by reducing the cerebral blood flow or by reducing the. Therefore, besides this, immediately after the brain trauma, the cerebral blood flow get adversely affected, especially during day 1. It can go below the ischemic threshold, and depending upon how severe is the injury and what management patient receives during this time, the blood flow may get restored, leading to good outcome, or it can remain low, leading to adverse outcome. And if the surgery is done during this time, it may represent the second hit because of the secondary changes it can cause. Therefore, it has been noted in the literature that when the patient is undergoing emergency extracranial surgery, there are very high incidence of hypoxic and hypotensive events. Intraoperative secondary insults are common, and it does lead to worsened outcome. So what should be the optimum perioperative management for this patient? Unfortunately, there is very limited evidence and there is great variability amongst the different centers. What we need to know: when was the injury, whether the injury is life-threatening or no, what is the surgery planned, is it emergency, How severe is the traumatic brain injury? And is there any need for neurosurgery or no? And if yes, which surgery gets more priority? Which one is more urgent? And are there any comorbidities or no? All these things we need to know and then focus on perioperative brain protection and cardiorespiratory optimization. The WSCS have given some guidelines for the immediate management in the first 24 hours. Like the major hemorrhage requires immediate intervention, but after the control of the hemorrhage, the TBI gets the urgent priority, and that needs to be diagnosed and managed. Patients at risk for intracranial hypertension require ICP monitoring, regardless of the need for emergency extracranial surgery. And these guidelines say that maintain the systolic BP above 100, HB above 7, PaO2 between 60 to 100, PaCO2 35 to 40 millimeters of mercury. And if required, use of osmotherapy or hyperventilation may be needed. As the time passes, the things change. After 48 hours of injury, most of the injuries would have evolved. There would be radiological evidence. Resuscitation would be complete and cerebral blood flow would be reasonably stabilized. So after this time, probably there would be less incidence of secondary brain injury or less risk of operating. Longer the duration since injury, the ICP monitoring becomes less mandatory, and even with the higher severely injured patient, the mortality rate is likely to be lesser. What about the severity of the injury? Orthopedic surgery has various guidelines have been given by them, and they are more or less in place. If the patient is conscious, no neurological deficit, if the CT scan is normal, the patient may be taken up for fixation under anesthesia, under appropriate anesthesia. If the GCS is 11 to 13 with normal or abnormal CT scan, but not requiring urgent neurosurgery, the non-urgent surgery should be withheld for 24 to 48 hours and repeat CT after that time. But urgent procedures should be taken up with intraoperative ICP monitoring using neuroanesthesia principles. For severe head injury, case-by-case decision should be taken. Only minimum tolerable intervention should be done. ICP monitoring is needed, and if it becomes unstable, then surgery may have to be stopped and urgent neurointervention may be needed. I have come across these two review articles. One is about the perioperative management of polytrauma patient with TBI, and it gives more or less the surgical perspective. And the anesthesia considerations are excellently given in this another review article written by our own team of anesthesiologists, the AIMS team, along with Dr. Bithal. Most of us know them very well, and one can go through these things. So to elaborate further, in neurosurgical patients, we prefer to give intravenous induction because of their favorable cerebral dynamics. However, in hypovolemic trauma patient, the thiopentone and propofol may cause significant hypotension and can reduce cerebral perfusion pressure. So in such a patient, etomidate may be preferred. Even ketamine has been shown to be useful in ICU setup, but not yet in the OT setup. The clear guidelines are still awaited. Whatever is the drug chosen, the intubation should be done with the proper appropriate stabilization of the spine because there is high risk of spinal fractures. Adequately paralyze and anesthetize so that coughing during intubation is prevented so that the ICP does not rise. And sedative and neuromuscular blockers are to be used cautiously if there is difficult airway. For maintenance, we do not use halothane in neurosurgical cases at all. Isoflurane, sevoflurane, desflurane, all will cause dose-dependent cerebral vasodilatation. And therefore, when these agents are to be used, keep the MAC below 1 so that the cerebral blood flow will not increase and it will not increase the ICP further. Nitrous oxide is again a vasodilator. So ideally, it should be avoided in severe TBI. And again, it is contraindicated if there is pneumocephalus or pneumothorax. Mental normocarbia, hypocapnia will put the patient at the risk of cerebral ischemia and also exacerbate hypotension in hypovolemic patient. Hypercapnia, on the other hand, can cause cerebral vasodilatation. This one article has said that this increase in ICP with hypercapnia is more significant for mortality if there is associated acidosis. Otherwise, there is raise in ICP, but it is not increasing the mortality. Transient hypocapnia is advocated only when there is impending cerebral herniation, awaiting emergency neurosurgery only. However, Brain Trauma Foundation has clearly said that prolonged hyperventilation is contraindicated. It should not be recommended. It is not recommended. What about PEEP? In neurosurgical cases, we do not use PEEP. But if the patient is hypoxic because of the polytrauma, hypoxic, and PEEP is required to maintain the PaO2, please provide it, but provide up to 12 millimeters of mercury and avoid hypotension. Higher PEEP is associated with the increase in ICP. So provide only up to the required and monitor the cerebral oxygenation. Intraoperative hypotension incidence is also very high, as high as 65% in these patients, and that needs to be avoided. Brain Trauma Foundation recommends that maintain the systolic BP above 100 to 110 millimeters of mercury, if required using volume expansion, vasoconstrictors, and inotropes. Invasive BP monitoring would be recommended to maintain the cerebral perfusion pressure between 60 to 70 millimeters of mercury. ICP is to be maintained between 20 to 25, and if it goes beyond that, use some agents like osmotherapy, hyperventilation, or decreasing the cerebral metabolism. In worst cases, even neurointervention may be required. Maintain euvolemia using goal-directed therapy based on dynamic indicators of fluid responsiveness, like PPV. Use isotonic crystalloids. Avoid hypoosmolar dextrose solutions. You may need osmotherapy like mannitol or hypertonic saline in these patients, even when they are not undergoing neurosurgery. Prompt replacement of blood loss would be advocated. The guidelines say that maintain the HB between 7 to 9, but if there is a risk of cerebral ischemia, the HB target increases to 9 grams per cent. These two ongoing studies, TRAIN study and Hemotion trial results, will be out shortly. So that will tell us exactly which particular target, hemoglobin target, would be best. Keep the platelet count above 1 lakh, INR below 1.5, using fresh frozen plasma, platelet concentrates, and cryoprecipitate. Mind well that traumatic brain injury is associated with very high incidence of coagulopathy. In our own one study also, we have found more than half patient of moderate and severe TBI patients having coagulopathies. Results of CRASH 3 trials have shown that if tranexamic acid is given within 3 hours of injury, it has improved outcome in mild to moderate TBI. So whenever given a chance, please give tranexamic acid. Both hyperglycemia and hypoglycemia are bad for the surgery, for the brain. So monitor blood glucose and avoid both. Avoid hypothermia, prevent hyperthermia. Steroids are contraindicated in traumatic brain injury. In fact, they are associated with worsened outcome. Anticonvulsants are to be given for at least 7 days post-trauma to decrease the incidence of early post-traumatic seizures. Mild to moderate patient, the traumatic brain injury patients may be allowed to wake up at the end of the procedure and consider extubation, but prevent coughing and bucking because it can increase the ICP. Severe TBI patients are not to be extubated and continue post-op ventilation in the ICU with monitoring and appropriate analgesia. What about regional anesthesia after traumatic brain injury? There is no role of central neuraxial blockade in acute polytrauma patients. The spinal anesthesia is in fact contraindicated because it can affect the CSF dynamic adversely and tentorial herniation can take place as the CSF shifts down. Even epidural anesthesia has been known to increase the ICP. Even 5-10 ml of local anesthetics can also compress the dural sac and ICP can increase. Later stages, it can be, the use of these blocks can be individualized depending upon the severity and the patient condition, but with caution. Peripheral nerve blocks may be useful. Femoral nerve blocks and all are good for the analgesia and traumatic brain injury patients. IV regional anesthesia has been known to cause a rise in ICP on tourniquet release. And when we use the sedation along with the regional anesthesia, the response may be unpredictable. There can be risk of respiratory depression or airway obstruction. Coming to second subject of discussion is epilepsy. About 5% of the population has suffered from seizures at one point of time or another due to various causes. And the most common cause for epilepsy is the epileptic focus. The other causes being presence of infection, electrolyte abnormalities, hypoglycemia, intracranial pathologies, or drug intoxication. Most of these patients would be on anti-epileptic drug therapy. Either they are receiving drugs that will suppress the excitatory impulses or drugs that will facilitate the inhibitory impulses. But unfortunately, most of these drugs also affect the actions of the anesthetics. The drugs which alter metabolism, especially the enzyme inducers, will make the patient prone to resistance to neuromuscular blocking agents like vecuronium. Whereas those drugs, phenytoin, valproate, carbamazepine, competitively bind to the proteins and therefore make the free drug, anesthetic drug becomes more freely available and there can be profound effect. So one has to titrate the effects. Usually these patients may come, pediatric patients for CT, MRI, dental procedures. The older patients may come for cesarean section or neurosurgery or incidental surgery. We need to know about the seizures, what is the type and frequency, which medications our patient is taking, how well it is controlled, whether recent changes in medications have taken place or no. And our objective is to continue medication till the day of surgery so that they do not get precipitation of the seizures. Also check the associated comorbidities. This drug also can cause fluid and electrolyte imbalance like hyponatremia, water retention, hematological problems like aplastic anemia, granulocytosis, thrombocytopenia, nutritional and neuropsychiatric problems. So additional investigations to identify this may be needed. Similarly, anesthetics can also affect the seizures. Nitrous oxide and sevoflurane are known proconvulsants. Isoflurane and desflurane are anticonvulsants and therefore are preferred. Most IV induction agents are proconvulsants in low dosage, anticonvulsants at high dosage. Benzodiazepines are always anticonvulsants and opioids are proconvulsants. Besides choosing anesthesia techniques and drugs wisely, we also have to ensure the adequate paralysis. So intraoperative seizures do not affect the surgeons much. Monitor the neuromuscular junction. Avoid risk factors for seizures like hypoglycemia, electrolyte imbalance, and so on. And use caution while giving regional anesthesia. Drugs like metoclopramide and all increase the frequency and severity of the seizures, so they are to be avoided. Seizures during anesthesia are relatively rare, but can occur in patients with poorly controlled epilepsy. But under GA, they are also difficult to diagnose. So keep an eye open on increasing ETCO2, tachycardia, hypertension, pupillary dilatation, and so on when they have the known history of seizures preoperatively. If that occurs, deepen the plane of anesthesia, give 100% oxygen, correction of the precipitating factors would be next. And if required, additional drugs may have to be given. Postoperative seizures are best to be prevented rather than treated. Therefore, have minimum disruption of their drug regime. Watch for the abnormal movements in the postoperative settings. And if that occurs, immediately identify, determine the likely cause, treat it, use benzodiazepine. Usually the mortality rate in epilepsy patient is the same as the non-epilepsy patient after surgery. However, the post-operative complication rate is higher in these patients. So monitor and observe those. Pregnancy has got very high incidence of seizures. It may be because of the epilepsy, eclampsia, local anesthetic toxicity, metabolic derangements, amniotic fluid embolism. Even the intracranial tumors also grow faster during the pregnancy and can precipitate the problems. Similarly, during pregnancy, these patients may have poor compliance to the drugs, altered pharmacokinetics and hormonal changes. And because of this, the seizures become common. So continue anticonvulsant therapy and prevent metabolic abnormality in these patients. If labor epidural analgesia is to be given, it should be instituted slowly so that the sudden local anesthesia concentration does not come. And if still the patient has seizures, provide proper treatment, airway oxygenation, control of the seizures, benzodiazepine. And if it is an eclamptic fit, then consider magnesium sulfate would be advocated. Coming to the next common subject, we all come across ischemic stroke commonly. Usually these patients are geriatric patients coming for the cardiac, carotid or orthopedic surgeries. Pediatric patients also can come for the moya disease, usually for neurosurgery, but can come for the incidental surgery. So the clinical spectrum of this patient vary widely. Some may suffer from stroke, have recovered and now ambulatory and good neurologically, or they may be completely bedridden, may have multiple problems like upper airway obstruction, hypoventilation, delayed gastric emptying, multiple pulmonary aspiration, associated medical diseases, DVT, and quite often they can be on antithrombotic therapy or other medications. So the main problems that we are tackling over here is anticipating is worsening of the neurodeficits postoperatively. We don't want that. And perioperative recurrent stroke. That is a stroke occurring either during surgery or within 30 days after surgery. Mind well, this is more common than we think. Just yesterday we did case coming for another surgery who had suffered for post-operative stroke just few days ago. The patients who are more at risk of perioperative recurrent strokes are the patients who are older, having previous stroke, cardiac disease, hypertension, those where the antiplatelet agents are suddenly stopped, statins are stopped, or those who are undergoing hypotension, anemia, dehydration, and so on. If these patients are undergoing very high risk surgeries like cardiac surgery or carotid artery surgery, the risk is extremely high. Unfortunately, perioperative recurrent stroke is associated with extremely high mortality. We need to have proper thorough preoperative assessment. The neurological deficit and recovery in function has to be asked in detail, especially ability to ambulate and communicate, because we do not wish to take away this ability when they are going home after the surgery. Look for the airway reflexes, ventilation and nutrition. How much time has elapsed in stroke also is important. The higher risk of repeat stroke occurs within the first 3 months, and document the deficits. Treatment you received during acute phase also becomes important, and associated systemic conditions are to be assessed. They are quite often on multiple preoperative medications. Antiplatelets, anticoagulant, we need to balance between the bleeding risk versus the stroke risk, and then accordingly either stop it or continue it. Most of the surgeries nowadays we can continue with the aspirin ongoing. Beta blockers are to be continued. Statins are to be continued, especially if it is started 2 weeks prior to surgery. It is good. Anesthesia techniques and surgery are to be chosen in such a way so that the cerebral oxygen delivery is optimized and minimize the hemodynamic perturbations. Anesthesia drugs are to be chosen which will preserve the cerebral blood flow. And intraoperative monitoring, we should have low threshold for invasive monitoring. NMJ monitoring is to be done on the normal side of the patient. and maintain normotension, normocarbia, normovolemia, and normoglycemia. Ensure adequate recovery of the protective airway reflexes. Quite often, they may remain suppressed for some time. An interesting observation has been done in stroke patients at the end of the case, called as differential awakening. That is nothing but the short-term unilateral delayed return of the motor seen on the affected side only. Usually that side may start moving about 30 minutes, 40 minutes late. So assess the neurological function at the earliest. If the new motor deficits are seen, then close monitoring and repeat CT might be indicated. And avoid dehydration and hypotension for several weeks post-operatively. What about regional anesthesia? It is considered safer than GA as the landmarks in the brain are preserved. However, there is no benefit if sedations are given. There are very few studies favoring regional in the literature, so one should carefully select the technique and coagulation status monitoring. Another subject which is now more and more frequently seen in our practice is the Parkinson's disease. About 3% of the patient of elderly population do suffer from this disease or do develop. It's a clinical syndrome occurring due to loss of dopaminergic neurons in substantia nigra, and the patients come with the rigidity, tremors, bradykinesia, shuffling gait, and quite often might not yet have been diagnosed, especially if they are having such non-motor symptoms like autonomic dysfunction, depression, psychosis, or cognitive changes, which are recognized as indicative of Parkinson's recently. Patients of Parkinson's may have double mortality rate as compared to those who are not having the Parkinson's disease. Since it is a disease of imbalance between dopamine and acetylcholine ratio, the drug treatment is aimed towards giving the dopaminergic drugs like levodopa, carbidopa, or providing anticholinergics. Unfortunately, these drugs also have systemic side effects. Levodopa may cause dyskinesia, orthostatic hypotension. Bromocriptine can cause hypotension. MAO inhibitors, along with opioids, may cause precipitate serotonin syndrome. And even if these patients lose one dose of the anti-Parkinson's disease, it may precipitate rigidity, loss of balance, agitation. Neuroleptic malignant syndrome also may get precipitated. Even the drugs that we use perioperatively like phenothiazines or metoclopramide can exacerbate Parkinson's disease. So usually in the preoperative patient, we need to see the muscle rigidity, weakness. Usually this is common to all. In respiratory system, we need to check for the obstructive or the restrictive ventilatory function. Cardiovascular system may show arrhythmia, hypotension or hypertension, GI disturbances, DVT, all those things need to be taken. Quite often they may also come for high-risk patients which are associated with higher mortality. As far as the disease is concerned, we need to know the duration of the disease, which drugs the patient is taking, and which surgery patient is undergoing. If it is elective, whether we have the time for optimization or no can be checked. But our goal is to minimize the discontinuation of the drug for less than 6 hours. If more duration is likely to be there for discontinuation, give additional dose intraoperatively through oral, through the nasogastric tube. As far as anesthetic agents are concerned, inhalational agents are good because they inhibit the synaptic reuptake of dopamine, so they are preferable. Halothane is arrhythmogenic, so avoid those. Sevoflurane can cause QT prolongation, and some of these drugs that the patient is on can also cause QT prolongation. So one has to check that the patient is not at the risk of arrhythmias and then only consider sevo. Ketamine can cause exaggerated sympathetic nervous system response. Propofol can cause dyskinesia, so it is the patient-to-patient decision, and thiopenton decreases the dopamine release, so it is not a good drug for Parkinson's disease. Opioids can also cause muscle rigidity. Whatever is the drug you choose, one must avoid the hypotension because this reduces the blood supply to the delicate vessels supplying the dopaminergic fibers. So avoid hypotension at any cost. Post-extubation, laryngospasm and post-operative respiratory failure are expected problems. So keep a watch on that. What about regional? Regional eliminates the drug interactions, avoid masking of the symptoms, and enables early mobilization. So they are relatively good. Safe use in select patients of Parkinson's have been reported, but bradycardia and hypotension must be avoided. Sometimes the tremor can be really problematic and it may become unsuitable alone. Coming to another common subject is the chronic spinal cord injury may come later on for the spine surgery, gastric, general abdominal or urological surgeries, or for baclofen pump insertion. They may be paraplegic or quadriplegic. They may have bradyarrhythmias, cardiovascular diseases. They may have compromised ventilation, but still adequate for the normal living. But sometimes they may have tracheostomy and ventilatory assistance might be ongoing. Repeated pulmonary tract infections. DVT incidence is almost extremely high. They can have impaired thermoregulation. Nutritional, psychological problems are almost always there. And one problem I would like to specifically mention is autonomic dysreflexia. Whenever there is a injury above the T6 level, if there is a stimulus below the level of injury, it can cause sympathetic activation and there can be massive disordinated autonomic response leading to increase in the blood pressure, headache, flushing, sweating, nasal congestion and all. The treatment is treating the cause, eliminating the stimulus. But if required, one can use nitroglycerin hydralazine nifedipine to reduce the blood pressure. So when such patients come for anesthesia, do we need to provide anesthesia? The answer is yes. If the surgical site is above the level of lesion, if the lesion is incomplete, if the patient has autonomic dysreflexia, if there is muscle spasm, provide anesthesia. But beware of delayed gastric emptying, identify patients who are susceptible to ADR, assess the airway, check the ventilation adequacy, sedative, they are more vulnerable to sedative effects, induction agents as well as opiates. So adjust the doses and titrate them. Careful positioning and temperature management would be required and ensure that there is adequate reversal of neuromuscular blockade so that ventilation doesn't get suppressed immediately afterwards. What about regional? They are likely to be causing less hemodynamic perturbation in response to the autonomic hyperreflexia. So titratable regional techniques may be used, especially in obstetric patients. It has been found to be useful. Spinal anesthesia is safe in abolishing the hyperreflexia. Epidural is relatively less reliable, especially in the general surgical and urological procedures. But determination of the higher level may become difficult. USG guided brachial plexus block also have been safely used in these patients. Chronic spinal cord injury with pregnancy. Uterine contractions are not felt if the lesion is complete above T5, but these parturients are at risk of autonomic dysreflexia if the lesion is high, especially when the onset of labor is a powerful trigger for this reflex and it continues for 48 hours postpartum. So in such patients, preemptively epidural analgesia is indicated and leave the catheter in situ for 48 hours. If required, use antihypertensives. Spinal anesthesia can be used for cesarean section with chronic spinal cord injury. Just a few words about peripheral neuropathy. There is some sort of injury occurred in peripheral vein. So these nerve fibers which are already compromised are more vulnerable to injury at another site on the same vein, another same nerve, another site or the same site double, and this can result into denervation of the nerve. So two low-grade nerve insults are dangerous. So understand the pathology, evaluate the risk benefit, and then only decide to give regional anesthesia. And when you do decide to give it, use the local anesthesia drug and the concentration judiciously. Overall, for all neurological diseases, regional anesthesia, it is contraindicated if there is increased ICP or unstable neuromuscular disease, but later on decision can be taken on the case-to-case basis. Thorough history physical examination is must, and evaluate and document the pre-existing neurological deficits. Take the consent properly, minimize the needle trauma, use smaller volume, less concentration of the drugs, and use of the vasoconstrictor is controversial. Also avoid the high inflation pressures and long tourniquet times in this patient. To conclude, patients with neurological diseases present for surgeries frequently. They are vulnerable to additional insults to CNS. One must understand the underlying pathology. Anesthesia management should be individualized so as not to affect the disease adversely, keeping close perioperative monitoring so that these patients go home back to their normal life without any additional neurological insult, and then no more disability is present. Thank you.
Thank you, madam. It was a wonderful presentation, and I'm sure that many doubts are clear about anesthetizing a patient of a neurological patient with previous stroke, convulsions, traumatic brain injury, Parkinsonism coming for non-neurological surgery. I would like to have expert comments from Konvilkar madam as well as Dr. Parak sir. Madam, please. Konvilkar madam.
Mangi, congratulations. As usual, it was a very scholarly talk, and that is what has been always expected from you. And although the list of these diseases are exhaustive, we have covered the most important and frequently seen disorder coming in for non-neurological surgery. Like we always get patients of polytrauma and always in a crossroads to think what is to be done first, whether the head injury or whether the orthopedic surgery. So many times we are in a puzzle what to be done first, and I think you have very nicely presented how to make the decision making in these cases, as well as Parkinson is also going on, and the other distinct disorder that we have, so pregnancy and all those things. So my query to you that query in the sense, my suggestion that diabetes is so rampant, and we get diabetic patient for any kind of surgery, not necessarily neurological surgery. So I don't think it is a habit for us or for the most of the people that I have observed to they will elicit the history of diabetes and the treatment and the control and uncontrolled and so many other things. But somehow to try to find out whether this patient has any symptom related to the peripheral neuropathy. So I think it should be mandatory in any diabetic patient to ask the history of peripheral neuropathy, whether they have symptom. Common symptom, whether they have fatigue, whether they have a burning sensation, whether they are any kind of this thing relevant to this thing. Of course, there are many more causes are there, but diabetic peripheral neuropathy is very common. So that's my suggestion to this forum that please do this thing, ask the questions which are pertinent and may give some clue that this patient does have some element of this. See, because you cannot really quantify that particular disorder. Rather, you can just establish it by the description of the symptoms. There are hardly any laboratory methods to say, well, this is the peripheral neuropathy because of this thing. It is always done by the by history of diabetes for so many years, and the symptoms they come and go away to this. So it is a very gray area, and I think we should all ask the distinct patient who are with the diabetic this particular symptoms regarding peripheral neuropathy, because it has a lot of distinct implication, as you said, that if we are using regional anesthesia in this patient, maybe that some patient may get worsened at the end of the your anesthetic, or if it is an initial state, it may progress further, and maybe sometimes it could be of a medical legal importance. So that is my suggestion to the entire forum today present on for this presentation. The head injury, of course, invariably in the this thing in our country, we are always late. We receive the distinct patient to the hospital care, and therefore more and more of the distinct pre-hospital care has to be emphasized. And there are hardly any distinct, only main metro cities which are there, they have the facility of this pre-hospital care has been given, and a lot of valuable and important that window period is lost by the time the patient really comes to the disease, and your secondary insult is already has initiated or it has already established. So the matter for this thing, people who are treating the patient, definitely in the hospital care becomes quite difficult. So these are my two suggestions, and of course, undoubtedly, once again, I congratulate you for a very informative this thing presentation on this particular topic. So over to my colleague, Dr. Don't give me smile, say something.
Yeah, so thank you, Dr. Himangi, for very elaborate and covering the commonest thing which we are coming across in day-to-day practice. The 5 or the 6, the diseases of the neurology which you have described. I think daily we come at least one. Okay, so that's and nicely you have covered what to do, what not to do. As you rightly said, any neurological patients coming for any non-neurologic disease, monitor brain. That is the keys word which you use, the monitor brain. So if you monitor brain in a like clinical aspects, that is the key for managing any neurological patient for non-neurological surgery. The one or two important thing which you have covered, right? Many times everybody gives dex steroids, but everybody gives it steroids and don't make injury. So on this platform, I want to highlight that steroids should not be used for any patient until unless is the indication which Dr. Himangi Kulkarni has already said what not to use steroids, because there are a lot of studies steroids are more harmful than any advantage. The other thing is anticonvulsants use. Many times people are not very clear when to use anticonvulsants. So you have highlighted when to do anticonvulsants, whether it should be covered, because many times you'll see patients coming for a like a non-neurological surgery and delayed patient, you see the delayed recovery from anesthesia. So there can be perioperative convulsions, that's the non-convulsive seizures, and when the delayed recovery from anesthesia. So the patient has already thrown convulsions and the delayed recovery from anesthesia. So one of the reasons for the neurological problems coming for non-neurological surgery is the delayed recovery. The other important thing which I want to highlight here is particularly many times you surgeons, when like have a patient traumatic brain injury and have a blunt injury abdomen, hemoperitoneum, the surgeon will say, no, I'll do laparoscopic. But be careful in the selection of patients for laparoscopic surgery, even for like diagnostic. So sometimes it's very problematic for the traumatic brain injury. So you must calculate whether you must see the preoperative condition and then allow the surgeon discuss these things in details for these things when they are coming for, because surgeons always say, no, I'll just put a scope, that's all. But once they put a scope, then they continue, then they don't see timing and all. So being an anesthesiologist, because you are the main in charge for the patient, be connected with the surgeon. Okay, that's the other important thing. And the other thing which perioperative, you have covered nicely about the stroke patients coming for the non-neurological surgery. But I would like to highlight particularly, every time any patients coming for stroke, please take a consent separately, because this stroke second time can occur anytime. It can be preoperative, it can be perioperative, it can be postoperative. So many times we don't explain these things to the patient. So when you explain these in preoperative, because you already have a stroke, and like previously, it has happened anytime. It can happen perioperative, postoperative, or anytime. So And we have we have stopped platelets and everything, so the become risk is more high. Sometimes can be dehydration. There are many reasons for these things. So please always try to say, explain them. Any patient has a previous history of stroke, take a separate consent. I have been explained that stroke can occur anytime. And as you rightly said, avoid any non-neurological surgeries in the first 3 months if it's not in an emergency. If it's an emergency, then it's okay. Another important thing which you have highlighted is the Parkinsonism. Many patients are coming, and you rightly said about the regional anesthesia and their role. Most of the patients with Parkinsonism is coming for the fractured hip, most of the time, or fractured fibula or humeral, lower limbs fractures with PD. So, as your regional anesthesia is relatively preferred as compared to the general anesthesia, but be aware about the hypotension, which I already highlighted in a detailed scale. We should avoid hypotension in these patients. And laryngosspasm, many times I've seen patients coming for with the Parkinsonism coming for other surgery. When we give GA, when they're coming out, the incidences of laryngosspasm, as you rightly said, is very, very high in these patients. So be careful, avoid the light planes and everything when we are extubating these patients. Regarding your chronic spinal disease, you rightly said the autonomic dysreflexia is you must remember all this term when you are treating any such patients. And I think most of the things you have covered. So these are the things which I want to say. Any other questions? If something there will take.
Sir, we will continue with the discussion.
Yeah.
Because the chat box has many questions for both the faculties. I think Dr. Sri Ganesh has almost answered all the questions.
Yeah.
Sir, but Dr. Sri Ganesh, I would like to ask you one question. For posterior fossa craniotomies, when the head is not kept on the head pin holder or a Sugita frame is not applied, which type of scalp block you would like to give? Like only posterior, this posterior part of the scalp you usually block, or you complete bilateral scalp block, blocking all the nerves?
It may not, the scalp block, the traditional conventional scalp block may not cover all the areas for the posterior fossa surgeries because C2, C3 branch is also supplied to a certain extent the lower part of the occiput. So that is one aspect. Second is most of the posterior fossa surgeries require head to be fixed. So again, a clamp will be placed. Very rarely in emergency scenario or in specific conditions, they will be placed on a horseshoe. But otherwise, pins are applied. So again, the conventional bilateral scalp block will help because these patients also get relieved from the diffuse headache. Sometimes it is not specific to the operative site alone. The operative site alone can be better managed with local incision site infiltration and potent opioids and NSAIDs in the post-operative period. But this will reduce the diffuse headache, which because of the position, because of the neck pain, which occurs because of position in posterior fossa surgeries, extreme flexion, extreme extension. These things also need to be taken care of for post-operative pain. So, but otherwise, for bilateral scalp block, along with the greater occipital nerve can be blocked lower down. Some of us do block the greater occipital nerve lower down. That technique, if ultrasound is available, can be used to block, will provide a better analgesia for posterior fossa surgeries. But midline incisions, bilateral is required.
So I just want to say one thing about this. As Dr. Sri Ganesh has very well described about the scalp block. But the one important thing is when you are remove the bone flap, just take a local anesthetic agent and put the patty full with the local anesthetic agent on the dura. Because many times, as soon as you complete your bone flap removal, when you are touching or when you are bipolaring or you are cauterizing the dural bleed, patients start shouting because that is the time when he develops pain. Because the local infiltration and all which we are given, it acts on the surface. It doesn't act on the dura. So as soon as you remove the bone flap, take a full big patty, local anesthetic agent and put on the dura for at least 2 minutes. And once that is there, the surface anesthesia for the dura, you can cauterize and you can go. Once you open the dura, then there is no pain.
I failed to highlight that in my presentation. Well, brought it out, sir. Thank you very much.
Thank you, sir. Another question to Dr. Sri Ganesh, sir. Sir, what drugs you are using for skull blocks? Bupivacaine, ropivacaine, and a percentage? Because there are many studies in literature, and the comparable studies, in fact, are published in literature for both ropivacaine and bupivacaine, and especially about the percentage, because you mentioned that 0.5% bupivacaine around 20 ml will be sufficient, and if you inject 2 ml at each point, that should be suffice. That should suffice the need. What about 0.25% drug and using more amount of drug? What is your experience?
Yeah, I use 0.25% bupivacaine, maybe around 20 to 25 ml, not more than that is generally required. Sometimes it may be difficult to restrict considering the weight of the patient. Some patients are not ideal, what we consider around 60 or above. They may be very low weight. In those patients, you may have to dilute it further so that the volume is achieved with same results. So that can be done, but I use bupivacaine. Ropivacaine very less because of the hospital supply. What is commonly available with us is bupivacaine. But ropivacaine can also be used. Maybe Anil Parag sir can add to that.
Yeah. Any adjuvants which you suggest? Dexmedetomidine along with bupivacaine?
I personally don't add any adjuvants to the local anesthetic that we use for skull block, but we use dexmedetomidine systemically. Okay. I give fentanyl before giving the skull block. Otherwise, patients are generally not cooperative for 12 injections. Nobody would, even I would not be ready for 12 injections in awake state. So I give fentanyl and start dexmedetomidine. Once they are sedated at cooperative, arousable, then we perform the skull block. So that takes care of the pain from the injection itself.
Okay, so my protocol, I would I never give the bolus dose of dexmedetomidine.
Yeah, no.
So yeah, so I start like 0.2 to 0.3 microgram to the beginning. As soon as the patients come in my recovery room, I start that. And once I'm ready for the, most of the time, like in a DBS and all, we do everything outside the OT, like skull block, and then we take the patient. But when the patient are for craniotomy, we usually give blocks inside the OT. So my protocol is like I use the Xylocaine with adrenaline, 10 ml, and I add 0.5% of bupivacaine in that. That's another 10 ml. So that adrenaline give little bit wrong, and I add 4 milligram of dexmedetomidine in sorry, not for dexamethasone, not dexmedetomidine. And because my boss used to use Hyalase injection in that, so if available, I still use Hyalase injection. And the effect which we usually like 4 to 6 hours, 4.5 hours routinely we do, and without any pain. And that's all. And as he rightly said, we usually require many times when you are not using this scalp insert, many times when you are doing frontal craniotomy particularly, we may not put on the, when we are not using navigation, no need to put the frame. That is, the patient is comfortable in horseshoe also. When you are using navigation and all, then definitely we have to use the frame. So most of the time I give once, that's a one side block only if suppose my craniotomy is very precise and headrest when I'm putting on the headrest. So I can avoid 2 injections and the toxicity of the drugs.
It depends upon the surgical choice, whether the surgeon wants to apply a Sugita-frame or a head pin holder, or if he is comfortable with horseshoe. Most of the times nowadays, they are avoiding horseshoe because of other complications like perioperative vision loss and all. So they are preferring Sugita-frame for posterior fossa craniotomies. Himani Karnik, madam, would you like to add something on this?
Just that giving anticonvulsants preoperatively, not forgetting anticonvulsants and antibiotics are extremely important in these cases. And we as anesthetists should not consider that it's not our part or anything. We have to ensure, because otherwise seizures during the surgery would be really problematic to manage.
Anita madam, any other questions for?
And what madam was saying about diabetes, peripheral neuropathy and diabetes, that was one of my hidden slide.
Sir, are you giving any additional LA infiltration at the end of the surgery before closing the scalp?
Yes, sir. So that is the reason I mentioned to keep the total volume and the dose on the lower side when we perform scalp block. As Parag sir mentioned, local anesthetic is also kept on the dura, and the initial local anesthetic effect is still not worn off. And second is invariably the surgeon will use for infiltration some amount of local anesthetic. It could be a different local anesthetic than what you have used. So I generally use only bupivacaine so that the surgeon can use local anesthetic infiltration at the incision site with lignocaine. And post-operatively also, most of our surgeons finish generally by 6 hours. If required, we will supplement incision site infiltration. The surgeon does it, and if required, we also perform second scalp block. But rarely that is required.
Okay, thank you, sir.
Sir, have you seen any local toxicity, local anesthesia toxicity in so many years you are practicing scalp blocks? I haven't seen any of the incidents. Maybe
I have not seen local anesthetics toxicity during because of the scalp block, but I have seen local anesthetic being directly injected in a craniosynostosis child.
yes.
And after that, I have mandated that none of the surgeons will use any local anesthetic infiltration with adrenaline in those small kids. Generally,
Yes.
they're 5 kg, 10 kg kids, and the margin of error is very, very less. So direct injection into the intracranial cavity can be catastrophic. We lost the child.
So, Dr. Sri Ganesh, as you rightly said, many times we consider like 20 ml, 20 ml or 10 ml. It's on our, like, we just think about that, but never do that. The important thing is you must first see what is the toxic dose of that particular patient. Many times the Indian female, they're like hardly 35, 40 kg when they are coming for the surgery. So when you calculate the dose of the local anesthetic, make a chart and put on the your board in the your operation theater. I always do that. And I put the what is the maximum dose I can give. So everybody is aware. Even surgeon when he's asking, Anil, has our dose is complete or I can still use more. So everybody knows. Even the staff. Even if you are not if you are busy somewhere and sister asks, give me some more local. So they irrespective because the staff changes. They don't know how much we have used before. So this is very important to keep a board and keep a track of the local anesthetic agent which we are using. So then you can avoid the toxicity.
If required, we can dilute. These are the
Absolutely,
small
yeah.
nerves, so not an issue. Besides that, if the drug is given too low, posteriorly especially, it can cause the brainstem anesthesia also. It can go in the foramen magnum. So one
There
has
is a
to
case
be
report. Yeah,
careful.
there is a case report about that. Yeah.
Thank you, Sri Ganesh sir. Anita madam, any questions are there?
No, actually,
Ganesh sir.
all the questions are answered by Sri Ganesh sir.
Okay.
All the questions that were there in the chat, he's typed and answered them.
Sir, I had read your article about on Thrive for awake craniotomy, which was published recently in Indian Journal Anesthesia. It was a
Yes.
case study, in fact, and it was a very nice article. And after that, we have also tried using it because HFNO was I would like to ask you, in fact, what is the difference between Thrive and FHNO? Because HFNO is now available after COVID eras in many of the hospitals. So, do you have any experience of using HFNO for awake craniotomies?
Okay, there are two types of high flow nasal oxygen delivery devices. One is the Thrive, which can deliver only 100% oxygen and therefore may not be advisable for prolonged surgeries such as awake craniotomies. They may be suitable for awake fiber optic or sedated fiber optic intubation, short duration, but for prolonged duration, 100% may not be advisable. So the airflow which is available in the most of the ICUs now post-COVID can be used, which you can use for titrating the FiO2. So we don't require very high FiO2, but we may require high flows. So in that particular report which we presented, patient had an intraoperative seizure and which was required to be terminated with the benzodiazepine. The patient could have had a desaturation that was prevented by using high flow nasal oxygen. And the second patient was an obese patient. Again, these patients are challenging. As Parag sir was mentioned, they use propofol. Propofol and airway obstructions are very well known. And once the head is fixed in, suppose in flex position, the margin of safety narrows down. So in those patients, again, high flow nasal oxygen may be beneficial in prevent. It provides some a little bit of at least extra PEEP than ordinary mask could provide. And also because of the high flows, you can avoid maybe any intubations or placement of the supraglottic airway devices. So these are the potential advantages which it has, but it is an upcoming, recently available tool for us. Maybe more and more use will provide us more information on how best to use, which cases to use, and where not to use.
See, as Dr. Sri Ganesh has mentioned about use of Thrive and the high nasal oxygen flow, but the important prerequisite of use is that the patent airway. Many times what happens when you're giving propofol and all, your airway obstruction is there. So when you're giving nasal oxygen, it doesn't go. It's not useful. So it is very important to use jaw thrust, in particularly in such patient, when even you feel that patient is now oversedated, as in Dr. Sri Ganesh's case, where the benzodiazepines is given or propofol, when they're snoring, just give a chin lift, and then you can use these devices. Or even like if suppose you don't have, everybody is not like Dr. Sri Ganesh who has a HFN or Thrive available in OT. So even like you put a nasal cannula, 15 liters of oxygen for some time. So you can avoid the hypoxia, and you can buy that particular time, particularly like 10, 15, 20 minutes without desaturating and giving harm to the patient.
Thank you so much, sir. Thank you for your expert comments. Anita, madam, any questions are there in chat box?
No, actually. No
One
new
question is there.
Hemani, madam, I would like to ask you one question. Many times people ask, can you give spinal anesthesia in a patient who has undergone a shunt surgery? So this question is asked many a times, like patient getting fractured femur, getting operated for fractured femur, and gives a history that a shunt has been inserted in his childhood. So whether a spinal anesthesia can be given to a patient who has undergone previous shunt?
There will be change in CSF dynamics, but just because we have given some amount of local anesthetics at lumbar level and all, it should not significantly affect the shunt functioning or so. There are many instances where spinal anesthesia has been given and nothing significant, means there are no issues with that. So that has been quite commonly happening.
So, madam, what is your view about laparoscopic surgery in shunt patients?
In shunt patients?
Yeah.
When there is increased intra-abdominal pressure, we have to assume that the shunt is not going to work for that much time.
Yeah.
So there can be increase in ICP. If they are going to give head-low position for laparoscopy, then it can further accentuate. So if the patient is shunt dependent and likely to get deteriorated because of that, then it's a big no. But people have done this both without any adverse problems and all. Usually these patients do tolerate block shunt for few hours. Yeah. So it is similar situation.
So now we use a lot of programmable shunts. So we can change the dynamics of the shunt.
Yeah.
So when you're doing such situation, when you really feel that yes, laparoscopic is more beneficial, you can have that change particular, or you can alter that. Thank you.
I think the risk-benefit ratio has to be in favor of any particular. That has to be communicated well to the patient and all the stakeholders, including the surgeon. I really don't understand why spinal anesthesia is contraindicated. You are injecting maybe 2 ml, 3 ml maximum in the subarachnoid space, and the shunt valve is unidirectional. So any increase in the intracranial pressure because of 2 or 3 ml should not be a major problem.
Yes, true.
Maybe the infection is the issue. If you are not taking care of infection, then those spinal fluid circulates into the intracranial cavity, meningitis, those are more serious issues than change in intracranial pressure.
Especially with VA shunt.
Yeah. So retrograde infections can occur from the retrograde infection.
Yes, true. Any other questions, Anita ma'am?
No, all the questions are answered in the lectures and after discussion itself. So everybody's no further questions.
It was really an excellent. Both the lectures were too good,
yes,
and they have answered all the queries.
Yes.
Thank you
Thank you,
all.
Dr. Saleh, Dr. Manisha Madam, Dr. Avinash, and Dr. Anita for giving us opportunity to share this platform with Dr. Hemangi and Dr. Sri Ganesh. Thank you very much. And Dr. Bharti Madam.
I think it is a frequent occurrence that me and Sri Ganesh are there somewhere in the same session.
Yes, yes, madam. Always a pleasure to be part of this.
My pleasure too. Yeah. Thank you all. Yeah.
Avinash
Thank
sir.
you.
Thank you, everyone. Thank you.
Yeah, just a minute, sir. Avinash sir will do the formality.
Oh, talks, thanks. Okay. Thank you, Dr. Sri Ganesh Kamath sir and Dr. Hemangi Karnik madam for the very informative, excellent, nice presentation. All these comments are from chat box only. Yeah? And so, actually, very nice presentation. I also thank Dr. Bharti madam and Dr. Parag sir, Anil Parag sir, for the moderating today's session and for the purse of wisdom. Thank you for the all who participated in today's session. I thank Varsha ma'am and our president Manisha madam and Anita madam. Thank you very much. I declare this today's session is over. Thank you very much. Good night.
Thank you, madam.
Thank you everyone.
Thank you.
Varsha madam, recording बंद करा. I will end.
Avinash sir, तुम्हीच host आहात. You only have to stop.
Yeah. Yes.
Chalo, good. We have
Yes.
finished. Yeah.
Stop. Now आपण आता डिस्कस करू शकतो.
समीर सर नमस्कार. मॅडम मला एक प्रश्न विचारायचा होता. ऍक्च्युली मी सगळं संपल्यावर विचारते. एका पेशंटला जे पेशंट्स those who come for surgery, non-neurological surgery, and the patients who have had previous stroke, usually I advise them color Doppler to see the neck vessels, like what is, because many of the times carotid blockage or internal carotid or so that is the reason. So me advise करते usually patients ना, if they a patient of previous stroke coming for non-neurological surgery. So let us just to let me know that what kind of carotid blockage is still there existing. कारण त्यांच्याकडे आधीचा रिपोर्ट असतो 60% ब्लॉकेज 50% ब्लॉकेज जेव्हा स्ट्रोक झाला असेल तेव्हाचा आणि दे कम टू सर्जरी आफ्टर 2 years. सो तो एक मला प्रश्न विचारायचा होता आउट ऑफ द बॉक्स आफ्टर द सेशन इज ओव्हर.
Say previous report would be there, current report is unlikely to be there, but even the previous report will say whether it is a bilateral disease or no. So some idea we can get from the previous one also. Besides that, the previously it will also be known whether the circle of Willis is complete or not complete. So some information we will come to know. Secondly, the treatment that the patient has previous stroke is also important. Like if the patient has already undergone the carotid endarterectomy or stenting or something, today that patient is less at risk. Yes. Or if the patient is thrombolized, then today we are not expecting that the circulation is that much compromised as against somebody who has not been treated, like those who presented late and the. No. Just yesterday we did one case where there was a previous stroke. Neck surgery was operated, patient developed immediate post-op stroke within 24 hours, came to our hospital, and yesterday we did his decompression craniotomy. The diagnosis was major MCA infarct. So yesterday was really troublesome that the patient will definitely have the repeat stroke because it was so fresh and so many factors were there. Patient was already on ventilator, so there was no clinical assessment judgment also. So risks are very high. Not every time we will come to know about the extent of the disease, but what we can do is what is the risk involved and how we can prevent it. Whether we know that whether opposite side is 60% blocked or not blocked, as long as we are maintaining the blood pressure, if that is our goal, probably we are safe enough. Or rather, that is the only thing we can do. So.
मॅडम आमचे म्हणजे सेरेब्रल पाल्सीचे जे येतात बच्चू किंवा काय, तर बऱ्याच वेळेला त्यांना कंजनायटल हार्ट डिसीज पण असतो आणि प्रोसिजर बऱ्याच वेळा खूप मायनर असते. तर अशा वेळेला काय
Anesthesia is never a minor.
नाही ते
Actually, cerebral palsy, multiple sclerosis, these are the slides that I did not show today because traumatic brain injury itself is a full-fledged time taking lecture. So then I had hidden that. But they are sensitive. They have very less muscle mass. And quite often they are very sensitive to neuromuscular blocking agents also. So I would go in for a doses which are titrated slow rather than the per kg weight and things like that. And muscle relaxants also very rarely required. We have done plenty of cerebral palsy cases coming for stem cell therapy. So the basic thing was they wanted to take up the bone marrow from the iliac crest and epidural catheter insertion. So non-neurological surgeries per se. And we could manage it with sedation and any sedative agents, but the dexmed ketamine combination we found to be very useful in them. Fentanyl was also useful, but then it can cause respiratory depression. So see.
Okay.
Thank you so much, madam.
Thank you.
Yes, thank you so much.
Thank you. Thanks for the opportunity and honor. The atmosphere is really good over here on this platform.
Yeah, madam.
Hi, Anita, I didn't talk to you.
The platform was full all the time. More than 100 participants had joined the program.
हो, आपली लिमिट 100च्या वर वाढली आहे काय?
आपण वर्षा मॅडमला विचारूयात. मला पण दिसले ते
112 114 दिसत होते, मला काय कळे ना.
5 मिनिटांमध्ये 107-9 झाले होते, त्यामुळे
मॅडम 100चा प्लॅटफॉर्म आहे, पण आज 110 112 114
परवाच्या ह्याला पण 101 2 3 दिसले आणि म्हणले काय आता त्यांनी वाढले काय आपल्याला माहित नाही.
वाढवली असेल,
ओके, दिली असावी ऑब्झर्व केलं. आता 110 पर्यंत जवळपास गेली होती.
सगळ्यात 100 फुल असतात, त्यामुळे दिले असेल झुमनी.
How much were paying to them?
सर अराउंड म्हणजे आपण नाही केलाय तो कॉन्ट्रॅक्ट. That has been done by this
previous body.
So it was around sir 40,000 पर्यंत आहे तो. We'll have to renew it in June, July. We'll discuss it in our meeting and we'll have to renew it. It was around 38 to 40,000.
खूप चांगला उपयोग होतोय बरं का. साळे सर आणि सगळे मनीषा मॅडम आता या 6 महिन्यात एवढा प्रचंड उपयोग आपला होतोय. एका दिवशी 2-2 सेशन्स आपण कंडक्ट करतोय या झूम प्लॅटफॉर्मचा. पैसा वसूल आहे माझ्या दृष्टीनं. म्हणजे या फॅसिलिटीनं उपयोग झालेला आहे आता या 6 महिन्यात.
जून जुलै पर्यंत तरी आता आपल्याला रिन्यू करायचा आहे कॉन्ट्रॅक्ट. अराउंड म्हणजे मागच्या जून जुलैला प्रिव्हियस बॉडीने रिन्यू केला होता. बिकॉज वी डू नॉट नो 4th वेव्ह 5th वेव्ह, त्यामुळे हा आपल्याला प्लॅटफॉर्म ठेवावाच लागणार आहे.
आपण औरंगाबादला भेटणार आहोत, त्यावेळी आपण बोलूया.
औरंगाबादला आपल्याला मिस्टर अभिजित भेटणार आहेत औरंगाबाद. तर आपल्या साळे सर, अनिता मॅडम, आपल्याला त्या वेबसाईट बद्दल चर्चा करायची आहे. आपल्याला सगळ्याच गोष्टींबद्दल त्यांच्याशी चर्चा करायची आहे.
ओके,
त्याच्या आधी आपण
आपला ड्यू आहे ते वेबसाईट आता का म्हणजे
वेबसाईट ऍप सगळंच आपल्याला डिस्कस करायचं आहे. So I hope everyone is coming to औरंगाबाद. सगळेजण येत आहे ना?
Manisha, Aurangabad, practically to start and reach Aurangabad on the same day, journey period is too high. म्हणजे 5 तास लागतील जवळजवळ नॉनस्टॉप.
सर तुम्ही येताय ना, पण मला पण 5-6 तास आहे सोलापूरहून.
पण कधी निघणार आहात?
सर प्रिव्हियस इव्हिनिंगला पोहोचायचं डोक्यात आहे, कारण सकाळी निघून पोहोचू नाही शकत. सकाळी म्हणजे पहाटे 4ला निघायला हवं.
4ला निघून म्हणजे प्रॅक्टिकली
10 वाजता तरी पोहोचायला. आणि वी डू नॉट नो रस्त्यात काही प्रॉब्लेम झाला तर त्याच्यापेक्षा आदल्या संध्याकाळी 2-3 वगैरे वाजता निघालं तर 9 पर्यंत पोहोचतो.
That is what I'm thinking.
आदल्या दिवशी या सगळेजण वी कॅन ऑल्सो डिस्कस समथिंग बिकॉज वी हॅव टू प्लॅन अवर मीटिंग ऑल्सो ऍट बोरिवली फॉर द कॉन्फरन्स. 22nd मे जी डेट आहे त्यासाठी. सो वी हॅव टू डिस्कस फ्यू थिंग्स ऑल्सो.
त्या दिवशी सगळे येणार असेल तर हे पण फायनल चर्चा करू ना मग
No,
संध्याकाळी.
Hemant is not coming. That's what I came to know. What about Samir?
बघतो
Okay.
अजून
नाही पण ये ना. ये.
अविनाश येणार आहे, दोघं मिळून आहे ना, तुला काय problem?
अविनाशला यावंच लागेल, सेक्रेटरी आहे.
मला यावंच लागणार आहे, ते येणार आहे.
त्याला ओढून घेऊन ये बरोबर.
Sir, I didn't ask Avinash. I'm expecting Avinash to come. So
हा ना.
तो काय तो इतका दुसऱ्या ह्याच्यात इतका गुंतलाय की तो इकडं काय फार वेळ देईना झालाय.
म्हटलं की इलेक्शन आता काय करतोय?
नाही
सांगू.
काय सर तुम्ही कधी येत आहे? When are you planning?
तो रात्री बसून आलं तर जमतंय का?
हो चालेल.
आम्हाला ड्राईव्ह करायला खूप लांब आहे.
किती आहे तुम्हाला?
संध्याकाळी काहीतरी असं मग
आदल्या दिवशी रात्री संध्याकाळी निघू बघू. काय एक ओव्हरलॅपिंग झालेलं आहे. म्हणजे एक कॉन्फरन्स आमची क्वालिटीची कॉन्फरन्स कोचिंगला आहे.
अरे बापरे.
द सेम डेट इज
कोचिनला? ओके.
ते
कसं काय शक्य होईल? म्हणजे तुम्ही तिकडे गेलात तर इकडे नाही होणार शक्य.
नाही आपण बरं का मॅडम
एक मिनिट.
एक मिनिट मी काय म्हणतोय का?
बाकीची बरीच मंडळी अजून लॉग इन दिसत आहेत मला.
त्यांनी
नाही,
कदाचित
Silent.
ऑन ठेवून
हा
तिकडे जात असतील ते.
We are not discussing anything.
नाही, दिसत आहेत मग आपलं सांगितलं.
पण त्यांना आता आपण we cannot remove them also ना.
नाही इट्स ओके, काय फरक पडतो. पण मी विचार करतोय रजिस्ट्रेशन ते कोचिंगचं केलेलं आहे 2 वर्षापूर्वी.
अरे बापरे.
हा ते कॉन्फरन्स पोस्टपोन झाली ना.
कोविडमुळे.
ऍडमिन रिलेटेड कॉन्फरन्स आहे ती क्वालिटी रिलेटेड. पण आता काय करायचं विचार करतोय वेदर टू गो आउट टू. बॅटरी संपली सगळी.
येस चलो. गुड नाईट एव्हरीबडी.
आपण पण we will discuss it. कधीतरी गुगल मीट वर सुद्धा we can discuss it.
हो
नाही आता
ग्रुप वर.
Come to औरंगाबाद, we will have some discussion. कारण प्रिव्हियस इव्हिनिंगला आला तर we can meet and sit and discuss. नाहीतर मग इनॉग्रेशन झाल्यावर we can sit together and discuss few things.
ओके ऑलराईट.
Because this person is also coming. आपले Abhijit is also there in India. He is managing everything at the moment from Italy, nahi, Germany.
जर्मनी. हा.
Akhilesh has left him. Akhilesh is not there with him. Now only Varsha is there in India. So मी त्या दिवशी बोलले त्यांच्याशी की तुम्ही अखिलेश आम्हाला दिसत नाहीये, तर अखिलेशला लोक डायरेक्ट फोन करतायत. तर आम्हाला म्हणे अखिलेशचा मोबाईल माझ्याकडे मीच उचलतो. पण दिस वी वर नॉट अवेअर. वी हॅव टू डिस्कस फ्यू थिंग्स. कारण एकटेक वर्षा इन इंडिया ती थोड्या वेळाने फोन करते प्रोग्राम सुरू झाल्यानंतर. मॅडम तुम्हाला होस्ट केलाय, अविनाश सरांना होस्ट केलाय आणि
नाही ती सगळ्यांना होस्ट करून टाकते. आता यावेळेला मला पण होस्ट केलं होतं आज.
ती होस्ट करते आणि देन शी लिव्हज. आणि मग काही टेक्निकल इश्यू आला तर तरी मी तिला सांगितलं दुसरं लेक्चर झाल्याशिवाय नाही जायचं. सो दिस इज रिअली इम्पॉर्टंट फॉर अस. नाउ ओनली वी आर 5 आर देयर. वी कॅन डिस्कस फॉर 5 more minutes before we leave the platform. So these things are म्हणजे बिफोर कंटिन्युइंग शाळेत स्पेशली दिस विल बी इन युअर टेन्युअर. कारण जून जुलै पर्यंत. सो बिफोर कंटिन्युइंग द सेम हे आपल्याला या गोष्टी त्यांच्याशी डिस्कस करायला लागणार आहेत.
पैसे भरायच्या आधी म्हणजे पुढचे.
हा पैसे
काय विषय
बर का सर्व बोलू शकता. मी सगळ्यांना रिमूव्ह केलंय. वी आर 5
आता बोला.
सगळ्यांना रिमूव्ह केलंय. आय एम
बेस्ट काम केलं.
बरं झालं.
काय असते बरं का मनीषा मॅडम, जरी असली आपलीच मंडळी असली तरी त्यांना शॉक बसू शकतो एकदम की काय चाललंय
सुरुवातीला
माहित नसतं ना.
नाही सगळ्यांना रिमूव्ह केलंय. फक्त आपण 5 आहे.
होस्ट असल्यामुळे त्यांना रिमूव्ह करू शकलाय तो.
मला तेच विचारायचंय की हे सगळे डिस्कस करायला पाहिजे. ऍक्च्युली ना त्यांचं हे छान आहे. म्हणजे त्यांचं म्हणजे अफोर्डेबल आहे. आताचं जे त्यांचं पॅकेज आहे ते कदाचित आय वुड लाईक टू से की मागचे 2 वर्ष हेच त्यांनी कंटिन्यू केलं होतं आणि फारसे प्रोग्राम झाले नाहीत. त्यामुळे त्यांना असं वाटलं की गेले शाळेसर गेले वाटतं. झाले
नाही त्यांची बॅटरी संपली म्हणले ना.
कॉम्प्युटरची बॅटरी संपली.
आपण 4 जणच आहेत. बोला.
नाही बरं का
मी काय म्हणतो,
मनीषा मॅडम
काय सरांचा फोन आहे?
हा,
हा सर,
अविनाश अविनाश
हम्म,
आता जे म्हणतोय ना आपण झूम प्लॅटफॉर्म ऍडमिनिस्ट्रेशन हा वेगळा विषय आहे
हा, ठीक, 2 मिनिटं.
आणि वेबसाईट ऍडमिनिस्ट्रेशन हा वेगळा विषय आहे. 2 सेपरेट विषय आहेत.
हो, ते दोघही त्यांनी त्याच्याकडनंच घेतलंय.
मी
म्हणून
त्याच्याकडेच आहे,
वेगळं-
दोन्ही त्याच्याकडेच आहे, हे बरोबर आहे. पण वेबसाईट आणि काय ते आपलं ॲपचं ऍडमिनिस्ट्रेशन, त्याचं अपडेशन ही टोटली वेगळी एंटिटी आहे. त्याचं टोटली बिलिंग वेगळं आहे, त्याचं कॉन्ट्रॅक्ट वेगळं आहे. आणि गेटिंग झूम प्लॅटफॉर्म आणि युझिंग इट त्याच्यासाठी वेगळे पैसे आणि वेगळे कॉन्ट्रॅक्ट आहेत.
आता जरी वेबसाईट उघडून बघितलीस आणि आता तरी
नाही काही चालत नाही.
पुअर शेप.
खूपच पुअर आहे. आणि पण मला असं वाटतं की हे सगळेच वेबसाईट डिझायनर खूप असं त्रासदायक असतात. जे हे लोकल असतात ना लोक, फार अगदी जे ऍडव्हान्स असतात, जे जास्त पैसे घेणारे तेच प्रॉपर सर्व्हिस देतात आणि त्यांच्या मागे सुद्धा आपल्याला खूप लागायला लागतं. अदरवाईज हा असाच सीन असतो सगळीकडे.
हो, तुम्ही कुठेही जा.
आयएसए नाशिकची पण वेबसाईट अशीच ती
शेवटी कसं आहे माहितीये का मॅडम, त्यांना टेक्निकल डेटा आपल्यालाच प्रोव्हाइड करायला लागतो.
हो ना, पण
एक्झिक्युशन हा त्यांचा प्रॉब्लेम आहे.
एक्झिक्युशनचाही त्यांचा प्रॉब्लेमच असतो.
आणि आम्ही जेव्हा सेक्रेटरी होते ना, खूप चीप वेबसाईट होती.
हा,
होती ती वेबसाईट कोणाची, अशोक देशपांडे सर तेव्हा प्रेसिडेंट होते आधी, आणि सांगली मिरजचा कोणीतरी माणूस होता. सो दॅट वॉज अ व्हेरी चीपर वेबसाईट. 5,000 रुपये वगैरे त्याचं वर्षाचं मेंटेनन्स होतं.
हा, हा.
त्याची काय कपॅसिटी जी असते ती पण कमी होती. पण जेवढं आपल्याला पाहिजे होतं ना, ते तो व्यवस्थित घालायचा. कारण मी सेक्रेटरी म्हणून त्याला प्रोव्हाइड करायचे, मला हे पाहिजे, मला हे पाहिजे, ही मिसा न्यूज पाहिजे, हे फ्लायर पाहिजे.
ते तू खूप चांगला फॉलोअप आणि रेग्युलर देत गेली म्हणून ते करत गेलं. ऍक्च्युली त्याच्यात काही एक विशेष नसतं. म्हणजे त्या एमबी केबी मध्ये ते बसलं की ते अपलोड करतात. त्याच्यात
फोटो पण नीट नाहीये. आता काय करायचं आपण?
बरोबर, ह्यांचा प्रॉब्लेम
नीट नाहीये.
मनीषा, आमच्याकडे आम्ही हॉस्पिटलसाठी पण घेतलेलं आहे पॅन्डेमिक चालू झाल्यापासून. मोस्ट ऑफ दी दिस थिंग
जॉईंड समवन हॅज जॉईंड. अविनाश,
हो, काम बघितले मी.
तर आलेत, साळे सर आलेत.
नाही, येस, ओके, नाऊ वी आर 5 ओनली.
काढते.
हा, काढले.
आमच्याकडे घेतलेलं आहे. समथिंग अराउंड 9,000 वगैरे काहीतरी दिलेलं आहे. बट वी कॅन हॅव 500 पीपल ऑल्सो. मी थोडं आता उद्या चौकशी करतो काय आमच्या IT डिपार्टमेंटने काय केलेलं आहे ते. आमच्या CMEs वगैरे ज्या कंडक्ट होतात हॉस्पिटलच्या, त्याच्यामध्ये ती घेतलेलं आहे. आणि मे बी आमचा डिपार्टमेंटचा सपोर्ट असतो, त्यामुळे आम्हाला बाकीच्या त्यांच्याकडून काही लागत नाही. बट दॅट इज लमसम प्रोक्युर्ड फॉर 1 year.
हो सर, हो मॅडम.
आमचं पण आहे ना झूम प्लॅटफॉर्म.
आपण या वेबसाईट
तर तो कुठल्या पण
आणि ऍप करता 2 लाख रुपये दिलेले आहेत. 2-2.25 लाख रुपये दिलेले बनवण्याकरता.
ते पण
आणि
जास्त
आता मेंटेनन्स ते अराउंड 25,000 ते 30,000 रुपये मागतायत. तर तो
मॅडम, मी
मेंटेनन्स आपण ऍटलिस्ट ती वेबसाईट तरी प्रॉपर आहे हे बघणं गरजेचं होतं. म्हणून आपली ती मीटिंग आपण घेतली होती मागची. बट इट एंडेड अप इन अ व्हेरी अग्रेसिव्ह वे. आणि त्याच्यानंतर तो अभिजित जरा नॉर्मलाइज झाला आणि ही स्टार्टेड टॉकिंग. कारण म्हणजे ती वेबसाईट ऍक्च्युअली ते ऍप जे होतं दॅट वॉज इंट्रोड्यूस इन बाय द प्रिव्हियस बॉडी, आणि त्यांनी ते पुढेच नेलं नाही. आणि आपल्यावर जबाबदारी टाकली की आता तुमचं तुम्ही बघा म्हणून.
ऍप वापरलंच गेलं नाही ऍक्च्युअली, त्यामुळे ते चालत नाहीये, लक्षातच नाही आलं.
माझा पॉईंट होता त्यावेळेस, म्हणजे जर अविनाश सर फेल लाईक दॅट की मी ओव्हर घ्यायच्या आधी सगळं बघायला हवं होतं की ते ऍप बद्दल वगैरे काहीच ओव्हर झालं नाही ना. बिकॉज आय वॉज कंटिन्युइंग फ्रॉम प्रिव्हियस बॉडी, आय वॉज अवेअर की हे ऍप आहे आणि ते काही इंट्रोड्यूस झालेलं नाहीये. त्यामुळे व्हॉट एव्हर मनी वॉज स्पेंड दॅट टाइम, त्याचा काहीच अजून यूज झालेला नाही.
आता आपली परिस्थिती अशी झाली आहे की 2-2.5 लाख ISA घातलेले तरी आहेत आणि त्याचा पुरेसे युटिलायझेशन झालेलं नाही.
आणि वेबसाईटचं नाही झालेलं आहे. दिस प्लॅटफॉर्म अराउंड
झूम म्हणून म्हटलं थांबा, एक गडबड आपण 2 गोष्टींची नको मिक्स करायला. झूम प्लॅटफॉर्मचा 100% पैसा वसूल आहे. दॅट इज डिफरंट इश्यू. एकदम ते काय युजिंगच्या ह्याच्याप्रमाणे 2 रुपये कमी जास्त वगैरे होऊ शकतं. ते त्याचा काय मला अडचण नाही. नाही, पण दुसरी गोष्ट लक्षात घ्या, ह्याचा जो डेटा म्हणजे मगाशी अनिता मॅडम तुम्ही म्हटलात की नाही, केबी मध्ये नाही चाललेला आता आपला डेटा, आपण
आता
सगळं
खूपच जास्त आहे.
हे सगळं रेकॉर्ड करतोय, हे सेव्ह करतोय, प्रचंड डेटा होतोय.
हो,
आणि
आता
या
टीबी जातच आहे.
स्टोरेजला आपल्याला बऱ्यापैकी पैसे द्यायला लागणार आहे.
बरं, आता अजून एक सांगायचं म्हणजे मला परवा कळलं कला ईश्वरनकडनं, इफ वी सबस्क्राईब फॉर MSCISA, युट्यूबवर आपल्या सगळ्या अपलोड होत आहेत, आपण मॅक्झिमम लोकांना सांगायला पाहिजे की यू सबस्क्राईब, देन द युट्यूब पीपल पे अस. जर मॅक्झिमम आपले सबस्क्राईबर्स झाले तर
बरेच संख्या लागते त्याची.
अरे पण आपण ऍटलीस्ट लोकांना, आपल्याकडे 5,000 लोक आहेत, सबस्क्राईब करायला सांगायला आपल्याला काय अडचण आहे?
म्हणून ते सारखं लाईक, सबस्क्राईब, शेअर ते जे सांगतात की नाही, तेच
त्याला ना असं मिलियन्स म्हणजे लाख वगैरे असे खूप असेल.
लाख वगैरे नाही, ऍक्च्युली अराउंड 10,000 वगैरे असा आकडा आहे.
अच्छा.
तर म्हणजे काही
Manisha,
नॉट बी बिग अमाउंट.
I'll suggest one thing. Why not to have our own YouTube channel?
आहे ना.
No, no.
सर, MSCISA चा YouTube चॅनल केलेला आहे आपला.
Automatically जाता है. All our 5,000 members subscribe for that.
We are uploading every activity on MSCISA YouTube channel. तेव्हा म्हणजे मी जेव्हा हँडओव्हर घेतला ना, चालू करून टाकलं होतं YouTube चॅनल. पण त्याच्यावर सबस्क्राईब
परत युटिलायझेशनचा प्रश्न आहे. युटिलायझेशन होण्याचा प्रश्न आहे.
काय होतं, आपल्याकडे रेकॉर्ड राहतोय प्रत्येक गोष्टीचा. रेकॉर्ड आहे आपल्याकडे, आपल्या जेवढ्या ऍक्टिव्हिटीज आज झालेल्या आहेत, एव्हरीथिंग हॅज बीन रेकॉर्डेड ऑन YouTube अँड स्टोर्ड ऑन YouTube.
गुड.
तो फायदा एक आपल्याला आहे याचा.
साळे सर, कदाचित तुमच्या हॉस्पिटलचा रेट जो काय ना, तर त्याच्यामध्ये फक्त झूम प्लॅटफॉर्मचा युटिलायझेशन सिंगल आहे. ऍडिशनल युट्यूब लाईव्ह स्ट्रीमिंग आणि स्टोरेज हे एक ऍडिशनल आपण आता वापरतोय. सो देर मे बी डिफरन्स इन द कॉस्ट.
असू शकतं, मला आता एक्झॅक्टली सांगता येणार.
समीर, आता आमचा ISA नाशिकचा आहे ना, तो काहीतरी 12,000 का 14,000 रुपये वर्ष असा आहे आणि 100 पर्सन्स पर मंथ, आणि महिन्यातून तुम्ही किती पण मीटिंग घेऊ शकता.
बरोबर.
आणि तो फारच कमी आहे ना. आणि
आता किती आहे?
दुसरा
तेवढंच आहे.
नाही, आपला 40,000 आहे.
नाही
नाही.
आपल्या 40,000 आहे.
नाही
40,000 आहे.
28.
अरे त्यांनी 28,000 का 29,000
28 आहे
जून जुलै
आपला. नाही पण ते विथ नुसतं आपण तो घेतलेला नाही. आपण जे काही त्यांचं कोऑर्डिनेशन आणि मॅनेजिंग आहे की नाही, ते पण त्याच्या सकट आहे. ते
तू
असतंच ना, आमच्या टीम पण आहे ते. युट्यूबवर आम्ही पण अपलोड करतो.
गेल्या महिन्यात आयडीकॉन IMA ची कॉन्फरन्स घेतली. 1100 जवळजवळ रजिस्ट्रेशन होते. 1000च आम्ही
सबस्क्रिप्शन.
पण ते 1 महिन्यासाठीच होतं. एक रुटीन 100चं घेतलेलंच आहे. फक्त कॉन्फरन्स साठी 1000चं घेतलं होतं. पण त्यावेळेला पण
अपग्रेड करता येतं ना, एखादा महिना आपल्याला अपग्रेड करता येतं,
पण तो
वेगळे पैसे भरून टाकायचे.
तर आपण नुसतं आपण झूम घेऊन उपयोग नाही. आता जे ते मॅनेजमेंट आपण जो म्हणतो ना, त्याचे चार्जेस आहेत त्याच्यात.
नाही, आमचा झूम आणि मॅनेजमेंट सगळ्याला आम्ही एवढे देतो. नुसता
12,000 आहे ना. 12,000 ना.
12,000 वर्षाचे. आणि ती मॅनेजमेंट सगळं ती करते. म्हणजे जी आमची होस्ट आहे ती कंटिन्युअस प्रत्येक मीटिंग मध्ये असते. उलट एवढाही गोंधळ होत नाही, ती लगेच म्यूट करते आणि कुठलाही प्रॉब्लेम आला तर लगेच ती हेल्प करते. आणि अपग्रेडेबल टू 500 आहे.
फारच छान आहे.
नाही आपण
सगळे फ्लायर, सध्याचे सगळे फ्लायर्स मॅडमची माणूस करून देते.
नाही, ती पल्लवी नाहीये, फ्लायरवाला दुसरा प्रिंटिंग वाला आहे. पण चांगली आहे. म्हणजे आता पिंपरी चिंचवडनी ह्या पल्लवीलाच हायर केलं. झूम वाली आमची जी आहे नाशिकची, पिंपरी चिंचवडची झाली ना, ती हिनीच करून दिली पल्लवीनी. आता मला वाटतं विमेन्स डेचा त्यांचा झाला.
नाही, आपलाच प्लॅटफॉर्म वापरला ना, जेनेकाचा.
नाही, आता जेनेकाचा वापरला असेल, पण त्या
पल्लवी आपलाच वापरलाय. आजचा पण आपलाच वापरलाय.
आपण तर मिसा तर आपण आपलाच वापरतो ना.
नाही, PCMCचा कालचा.
PCMC का? अच्छा.
म्हणून तर ते बॅक टू बॅक ना, लिमिट, टाइम लिमिट होतं. दुसरी झाली.
देयर वॉज अ इन्क्वायरी फ्रॉम डॉक्टर सीमा सूर्यवंशी. तुमचे फ्लायर्स एवढे चांगले का व्हायला लागले? मी म्हटलं आज डॉक्टर ललिताने की ते तू करून देत जा आम्हाला. तर तर त्यांचा माणूस करून देत आहे, त्यामुळे ते कदाचित तुला त्यांनी फ्लायर तुझ्याकडनं कारण जेनेका मला फ्लायर अजिबात चांगले करत नाही, कॉन्ट्रॅक्ट मध्ये आहेत.
फ्लायर वाला दुसरा आहे आपला अथर्व प्रिंटर म्हणून.
नाही त्याला काढून टाकतं की ते गोष्टी आपल्याला नाही पटलेल्या, आपल्याला सोयीच्या नाहीये करत, आपल्या सोयीप्रमाणे करायला पाहिजे ना, तर पैसे कोणाला तरी द्यावे लागणारच आहे.
हो बरोबर.
डिझाईन करण्याला पैसे द्यावे लागतात, म्हणजे ते काय फुकट कोणीच करत नाही.
काय 100 रुपये पर फ्लायर.
हा पण
सध्याचे आपले फ्लायर एकदम इम्प्रूव्ह झाले ना. मला सांगितलं सीमाने मॅडम महाराष्ट्राचे फ्लायर एवढे इम्प्रूव्ह कसे झाले तुम्ही कोणाकडनं करताय, कारण दे आर ऑल्सो अनहॅपी विथ जेनेका फॉर द फ्लायर्स.
त्यांनी कॉन्टॅक्ट केला ना, ते पण आता ह्याच्याकडनंच घेतात करून.
मी सांगितलं त्यांना की आम्ही अनिता मॅडमच्या माणसाकडनं करून घेतोय आणि आम्ही त्यांना एकदम ते झाले की पैसे देणार आहे. आम्ही सर तुम्हाला खूप जणांचे पैसे द्यायची झोळी उघडायची आहे.
बरं आपण आता
या आणि चेक द्या.
हा आपण डिस्कशन आता इथं थांबूया. आपण आता असं ठरवू की आपण औरंगाबादला आपण सकाळी भेटू लवकर आणि हो आणि मग बाकीच्या गोष्टी आपण
औरंगाबादचा प्रोग्राम सकाळी 8 वाजता चालू होणार आहे.
हो सर, आपल्याला शाळा करत बसता येणार नाहीये. अकॅडमिक ऍक्टिव्हिटी नाही, आपली मीटिंग करण्यासाठी आपल्याला जमायला लागणार आहे. अकॅडमिक शाळा चालू राहील त्यांची काय असेल ती.
आपण इनॉग्रेशन झाल्यावर बोलूयात ना, म्हणजे
वेळ नाही मिळणार आपल्याला.
इनॉग्रेशन आणि 11-12
तेच सांगतोय. नाहीतर शाळा ऐकत बसलो तर वेळ मिळणार नाही असं म्हणतोय मी.
11-11:30 बाहेर जायचं, एखाद्या रूम मध्ये बसून बोलायचं.
हा बरोबर,
ठीक आहे,
तसंच करूया आपण.
सर पॉइंट्स काढून आणा बोलायचे, कारण त्याच्याशिवाय मग नाहीतर आपला गप्पा सुरू झाले की वेगळेच विषय सुरू होतील असं होतं ते.
हो नाही, म्हणूनच मी मध्ये मध्ये ब्रेक करतोय. हा तर आपण भेटूया औरंगाबादला.
सर प्लॅन करा, कोची कॅन्सल करा आणि औरंगाबाद प्लॅन करा.
आपल्याला 5 जणांना भेटलंच पाहिजे. हेमंत नाही का येत आहे?
हेमंत नाही येत आहे.
ठीक आहे, आपण 5 जण तरी भेटणं आवश्यक. रात्रीचं बुकिंग करा, गाडी कुठली असते काय ते.
औरंगाबादची संध्याकाळ रात्री गाडी आहे ना, 11 वाजता आहे, 12 वाजता आहे,
काय असेल ते. 12
सकाळी पोहोचते 6-7 वाजता. 2 वेळा औरंगाबादला गेलेलो.
ओव्हरनाईट ड्रायव्हिंग तर नाही बाबा आपल्याला आता जमणार.
नाही बाय, चला.
अरे एक काम कर,
बोला की
तुझी गाडी घेऊन पुण्याला ये. तुझी गाडी इथं हॉस्पिटलला, इथनं जाऊ पुढं.
म्हणजे कधी?
अरे पुण्यात निघायचं, तू सकाळी निघ ना तिथून. 2 तास लागतात तुला पुण्यात यायला. पुण्यात जाऊ दुपारी 1 नंतर.
शनिवारी सांगताय सर तुम्ही म्हणजे?
हो सर, आम्ही शनिवारी ते 10 वाजता पोहोचलो ना, तर आम्ही पहाटे 4 वाजता औरंगाबाद मध्ये पोहोचतो.
गुढीपाडवा आहे, अगदी 12-1 निघणं जरा कठीण आहे घरात.
अवघड आहे हो.
त्या दिवशी गुढीपाडवा आहे शनिवारी. चला बायको जेवायला बोलवते. चला
आली दारात उभी आहे.
दर्शन होऊ दे. होऊ दे. हॅलो. आता समीरनी जेवायला भेटायची वाट बघतोय आम्ही, म्हणजे घरी येता येईल. अविनाश आणि समीरच्या
ओरडा चालू आहे. गोळी खाऊन झाली, 20 मिनिटांना जेवायचं असतं, 45 मिनिटं होऊन गेली. ती काय असते ग? कॉम्बिग्लेस नाही, ग्लायसिनॉर्म खाऊन झाले 45 मिनिटं.
काय असते ग
मॅडम? ते काय एवढे आनंदित दिसतात माहितीये का तुम्हाला?
आता सांगूनच टाकतो, पोरीचं ठरलेलं आहे.
डोळ्यावर एवढा हसते दोघांच्या.
अगं हे आताच चाललंय, हे सगळं गेल्या 15-20 दिवसाचा खेळ चाललाय.
दोघांचा एवढा आनंद का ओसंडून का वाहतो हे विचारा आधी.
काय झालं कळलं नाही नीट.
माझ्या पोरीचं लग्न ठरलं.
अरे वा, कधी आहे?
व्हेरी गुड.
डिसेंबर. हो, आणि तुमच्याकडे दिली सर पुण्याला.
व्हेरी गुड.
काय आहे मुलगा? डेंटिस्टच आहे?
होय, पोस्ट ग्रॅज्युएट.
तिचं तिनेच ठरवलेलं दिसतंय.
अनुरूप विवाह संस्था.
माझ्या पोरीला मनापासून हसू आलं हे ऐकून.
ऐकते वाटत
म्हणून
म्हणते जरा नाही, जवळ आले. बाकीच्या सगळ्या साखरपुडा पुढच्याच महिन्यात
म्हणून
आहे.
म्हटलं जरा मोकळा राहा थोडा, लग्न होईपर्यंत जरा बाकी ठीक लक्ष दे थोडस, नाही तर सारखं.
तू काय कर आता, सगळी कामं करून टाक ट्रेझररची या 15-20 दिवसात. म्हणजे
कशी?
काय आता लोकांकडनं पैसे घ्यायचे आपल्याला, ती कर.
त्याला मी तेच
ट्रेझरचं काम पैसे द्यायचं नसतं, आधी पैसे घ्यायचे असतात.
आण दे.
मी तर त्याला आधी सांगितलंय, त्याची कामं माझ्याकडे दे, मी सगळे व्यवस्थित करतो, तू माझी कामं कर, मला आवडेल.
कळले काय गडबड काय आहे ती, असं आहे.
लग्न डिसेंबरला का साताऱ्यात आहे?
डिसेंबर मध्ये.
हो, साताऱ्यात आहे की पुण्याला आहे?
साताऱ्यात.
ओके ओके.
17 एप्रिलला पुण्यात साखरपुडा, म्हणून जरा ते असं 3ला.
समीर, मी 6 महिन्यापूर्वी याला विचारलं होतं बरं का.
हो, माहितीये तिला, तिच्याशी बोलली होतीस तू.
ओके बाय.
तुम्ही नाही, आता तू.
लग्न नाही करायचं पोरीचं.
ते
गुड नाईट.
मागच्या वर्षी बोलणं झालं होतं तेव्हा तिचं नाहीच होतं.
आता ठरलं, अचानक तयार झाली.
आता 2022 मध्ये मी तिला सांगितलं की आता तू काही बोलायचं नाहीस, मी म्हणेन ते ऐकायचं.
बरोबर.
ठीक आहे,
चला,
गुड, कॉंग्रॅच्युलेशन.
ओके. एंड करू का मीटिंगचा?
Okay.
भोसले सर आता मीटिंग एंड करून टाक.